Good afternoon, everyone. Thank you very much indeed for being here. It's wonderful to see an almost full auditorium. We're talking about the 5,000 transplant milestone this afternoon. It's wonderful to see so many colleagues from over the years, so many patients, see everyone all together. What we're talking about this afternoon is what's happened since 1975. There have been more than 5,000 transplants since then. In fact, we met that milestone just before COVID. There's been increasing volume. There's also been increasing scope, this range of different transplant activities. And the speakers this afternoon are going to address all the different things that we do now and how those things have come to pass. And some, of course, are mainstream services like our kidney transplant service. Some are much newer, much smaller volume, much more, if you like, novel. You'll hear about all of them. And particularly based on the discussions, the talks we were hearing this morning regarding the legacy of Sir Peter Morris, the integration with the university remains an important part of what we do, a very important part of the Oxford Transplant Centre. We're very fortunate to have a very well-defined entity called the Oxford Transplant Centre. It has its own building, it has its own identity, but we're very keen that it should also be seen as having an intimate link with this very, very powerful academic powerhouse, which is the University of Oxford and the Nuffield Department of Surgical Sciences. So thank you again for coming. It's a great pleasure to introduce Phil Mason, who has been a really important part of this story, as he will tell you, since the mid-1990s.
Good afternoon, everyone. So I'm going to be talking about the kidney side of things, first of all. And Peter said 5,000. Well, it's nearly 6,000 now. It's made up of kidneys alone, almost 1,000 kidneys together with pancreas. And as Peter alluded, there are some other smaller volume, more recent transplants that have been carried out in the Oxford Transplant Centre. But adding up all the kidneys together, including the 2 that were done yesterday, it's 5,559. Again, most of them are with on their own, but there are some with pancreas, bowel, and also with islets. So just to remind people about how important we are slightly less responsive. I don't think I bother with the laser pointer, but basically, as you can see, this is the most recent data available from NHS-BT, which shows the graft and patient survival, patients transplanted 10 years ago, which is the pink line, which goes to 10 years, 75% 10-year graft survival. And so the average is well beyond that, and patient survival about the same. Remembering, of course, that as the years have gone by, we're transplanting people much older than in the 1970s and 80s, and we're transplanting a reasonable number of over 80-year-olds. You can probably see the different colour lines, as you can see from the key there, are the... I don't seem to be able to make this work very well. The green line is the most recently transplanted patients, and I think there's an indication that graft and patient survival is improving as the years are going by. And outlooks are even better for the living donor transplants, 83% 10-year. Perhaps I can use this actually. So even better living donor graft survival, 83%, and 86% patient survival. So what's happened over the last 30 years or so? Well, there's been a significant reduction in the waiting time for deceased donor, and at least until COVID, the actual active transplant waiting list nationally had actually been falling. It's climbing a bit now. So how long do patients have to wait if they haven't got a living donor? And the answer is the average is about 18 months nationally. And you can see there's a range. These are the 23 UK transplant units which have their median waiting times. Oxford and Cambridge vie every year for who's the lowest median wait time. This year it happens to be Oxford. Last year it was Cambridge. Okay, so what else has happened? We have a high rate of preemptive transplantation. So patients get a transplant before having to go through dialysis. We've now, as you heard this morning, developed blood grouping compatible and initially HLA tissue antibody incompatible transplantation. But we're early adopters of the kidney sharing scheme, which of course allows you to transplant patients by swapping kidneys. And for those of you, just a reminder, we actually put patients who've got a compatible donor if they're young, and we want to try and get them a better matched kidney. We put them into the kidney sharing scheme. Important for the young patients who may need to have a second transplant. And as you heard this morning, once you have one transplant, there's a risk of you becoming sensitized, making it more difficult for a subsequent transplant. So the kidney sharing scheme started in 2007 and was initially two-way. So there was just a swap between donor and recipients. Then the following year, three-way matches were allowed. And then in 2012, altruistic, non-directed altruistic donors were entered into the scheme, which meant that if you had a donor who was difficult to match, perhaps they were blood group AB, which is quite unusual, then the non-directed altruistic donor can kick off the chain, and then the final donor donates into the pool of deceased donor waiting patients. And then a few years later, the longer chain altruistic donor chains were allowed. And in 2018, there was a change where every non-directed altruistic donor was encouraged to put themselves up for the chains and entering into the kidney sharing scheme. And of course, that was a disadvantage to the donors because they couldn't choose when their operation is going to be. And once the sharing scheme had come up with some matches, then the individual units had to negotiate a date to do the transplants, although now some of the transplants are non-simultaneous. And the non-directed altruistic donors has had a huge benefit in increasing the number of transplants. So if we just look at the two lines that I've ringed, you can see back in 2014, there were 110 non-directed altruistic donors, which enabled 133 transplants. By 2019, when all non-altruistic donors were encouraged to participate in the kidney sharing scheme, you can see there were actually fewer donors that year, but it enabled far more transplants. So these are far more patients getting transplants. We've already heard from Bob Montgomery about a laparoscopic donor nephrectomy, which has been a huge revolution for the donors. There's been newer drugs to improve graft survival and patient survival. And the unit's been very active, continue to be very active with clinical trials, especially the 3C study, which looked at two aspects of induction and maintenance immunosuppression. And that was the largest, and still is the largest, investigator-led transplant trial. It recruited 850 patients, and actually, unlike most trials, recruited ahead of target. And there's been several trials and development of machine perfusion. You may hear more about that later on. And then increasing laboratory input into looking at patients who've got many antibodies and trying to find ways in which we can tweak the profile to increase the numbers of patients getting a transplant on the deceased donor waiting list. So the waiting list, this is basically looking at the degree of sensitization and the average waiting list. So down here, these are patients who are not sensitized at all. And it's only when you start to get up to very high levels of sensitization, so they're sensitized to the majority of donors that are being coming into the deceased donor pool, and these patients have to wait a long time. By using the methods that we've developed with the clinicians and the laboratory, actually 35%, almost more than a third of the patients who are highly sensitized, by tweaking their profiles, we've managed to transplant them. And there are newer treatments recently approved by NICE, fairly expensive, but they may well be the answer for patients who are even more highly sensitized. But of course, it's a team effort. It's not just the surgeons and nephrologists, it's the laboratory team, our pharmacists. We've got a wonderful pharmacy backup service in Oxford, our anaesthetists and cardiologists, critical in helping us decide the risk for patients and any interventions that might be needed to improve their outcomes. Our living and recipient donor coordinators, the advanced nurse practitioners who are doing quite a lot of the follow-up these days. And we have a strong psychology and psychiatric support, patient support, and of course, the patients and the donors that have enabled us to carry on increasing the numbers of patients we're transplanting. And I think that was my last slide. And now I'd like to introduce Dr. Sean Scott, who is one of our non-directed altruistic donors.
Thank you very much, Phil. So I'm aware that I'm an extra case on this list, so I'll be really quick, like surgical 5 minutes. Organ transplantation is a bit like a moonshot, and it's a monumental team effort, as Phil said. NASA said once that it was optimists that got us to the moon, but it was pessimists that brought us back home. And the transplanting team encompasses all of that spectrum, including the naysayers, trouble spotters, planners for the worst, or as you know them, anaesthetists. I've gone to great lengths to implant an anaesthetist into this program, so as to give a shout out to the real transplant anaesthetists, both past and present, who have contributed so much to the development of this service over decades. Although I'm not brain dead and I can ride a bicycle, I'm not here as an anaesthetist. 5 months ago, I donated a kidney to the transplant service, initially as part of a short chain. Unfortunately, the chain broke, so I ended up in the pool by myself and donated to somebody on the excuse me, on the waiting list. Like all quests, the duration of deliberation far exceeded that of execution. I had wanted to do this ever since, as a junior doctor, I first encountered DBD donation more than half of my adult lifetime ago, and I must express my gratitude to my family, friends, and colleagues, and to the transplant service for putting up with me and also for allowing me to realize this. Through thorough planning and preparation, and thanks to the skill and expertise of Richard and Simon and the teams that they led, my procedure was uneventful and my recovery was spectacular, which manifest as my early mobilization, lack of any pain or nausea, and absence of any other problems. I had chosen to not have a spinal as part of my anesthetic, as I had prioritized early mobilization, and I had trained specifically for that. So immediately after my surgery, I was able to move around. Apparently, I hugged everyone. I was able to walk within 8 hours post-op on the ward, having been decatheterized, and I needed only paracetamol for analgesia during that first night. I had been well established on a low carbohydrate ketogenic diet for athletic reasons for many years before that, so I was well tolerant of fasting on that day, and with stable glycemia and no hunger, I didn't need to eat for all of that afternoon, so I had no nausea, and which I attribute to that stable fasting and lack of need for any opioids. The next morning, I was able to dress myself, which seemed like a major achievement at the time. I walked downstairs to get coffees, walked back upstairs to get selfies in the roof garden, and promptly got discharged, probably because I was being a bit annoying. And I was home by 9 a.m., less than 21 hours after the end of the surgery. So, excuse me. At home, I needed only single doses of tramadol on the second, third, and fourth nights post-surgery. I needed no other opioids. I had been issued with a large bottle of Oromorph, which I returned to the pharmacy unopened a few weeks later. I walked every day, totaling more than 20 miles a week, and by 3 weeks, I managed to fulfill a promise to be well enough to go away on a mini break. So we flew away, and I was able to run on a beach and swim in the sea at 3 weeks post-surgery. By 6 weeks, I returned to my daytime clinical work, including daily cycle commuting, and then soon thereafter resumed all of my after-hours duties, and I recently enjoyed some all-nighters with the transplanting. Earlier, I mentioned some benefits of ketosis, and it's important to note that endogenous ketosis means more than just measuring numbers or a specific hormonal balance, but implies active lipolysis, upregulated fat oxidation, and gluconeogenesis, and that this milieu is so very different to exogenous ketosis, which is quite prevalent in the literature. So besides the metabolic stability and fasting tolerance, I believe that this broader ketosis physiology is of specific benefit in the contexts of donor and donor organ optimization, with potential benefit in normothermic perfusion and in providing a quiescent milieu for organ and potentially islet implantation. Obviously, I'm limited by time, so I'm not going to speculate further. But at this stage, all I'd claim is an anecdotal demonstration of the feasibility, if you like, of the maintenance of physiological ketosis during surgery. And I think one of the next moonshot lofty goals is to improve awareness and acceptance of the live donor program, in part by recognizing that even so-called altruistic donors are not untouchable. And I think that research into various factors that may improve outcomes in live donors as well as of their organs is interesting, and may improve the visibility and promotion of live donation. I'll close by saying thanks again to Richard and Simon for keeping my Jenga together, to Z Akhtar for helping me to join the dots, to Sanjay and Phil for their early guidance, and to Anna and Nikki for the care and support that helped make the process all so seamless. One brief addition, I now know to thank Professor Montgomery for establishing laparoscopic nephrectomy. I'm not sure that I would have gone through it the other way, but it was a wonderful experience, and I'd gladly do it again.
Thank you very much, Sean. So I got the order wrong. It was supposed to be Mr. Sen first before Sean, but it's now Mr. Sen's turn. Mr. Sen is a deceased donor recipient from 11 years ago? 9.5 years. And you're going to give us your perspective on Thank you very much, Mr. Sen.
Gosh, so many distinguished people. I hope I don't stutter and think what I have to say. I'm 83 plus at the moment. I had my transplant 2 days before my 74th birthday. I had a blood test in Churchill last week, and my creatinine level was 87. I hope that was correct. And I hope it carries on. The problems, my kidney problems started when I became diabetic at the age of 45. And within 2 years, they found protein in my urine, slight traces of it. And it wasn't, they didn't sound very worried about it, but they gave me a lot of medication for high blood pressure, and I controlled my diabetes on oral medication. This went on for 25 years. I had a young family then. I led a normal life. I traveled all over the world. I love traveling, and I'm also a foodie. So lots of good food, but under control. The trouble started in 2009 when I was 69. I flew back to London from Sydney, and that was a 24-hour flight. I didn't stop in Singapore. And when I got back, I had terrible swelling in my feet, both my feet. And I couldn't walk. It was very painful. I became bedridden. They thought it was gout, but it wasn't gout. And they couldn't understand why I was getting that pain. They even suggested it's something to do with the metatarsal, but there was no conclusion. After about 3 months, the pain subsided, and I was carrying on, but I noticed a lot of problems started. I began to feel tired. I also got the usual symptoms of kidney failure, I think, but I didn't recognize them. I'm a layman, I didn't know what problems were. And had shortness of breath, nausea, and it carried on for a year or so. And then I was sent to a kidney clinic whereby the Imperial College nephrologists were monitoring me. In January 2012, my creatinine level shot up to about 270. And they suspected the worst. And since, and within 6 months, it came down to 8. So I started dialysis at the Hammersmith in London to be stabilized. There, within a month, I met a consultant nephrologist who saw me for the first time and said, "You are a transplant patient." I wasn't surprised because the other patients were, I mean, I looked fit compared to the other patients that were there. So, but it gave me a lot of encouragement. Being stabilized, I moved to Windsor Dialysis Centre, and there, the consultant that was running the place discouraged me a bit for getting onto the waiting list. By the way, the consultant nephrologist at Hammersmith began to get me started on all the tests to be on the waiting list. However, I met Sanjay Sinha, who saw me, and after a couple of months of being in Windsor, because I had to have a fistula put in, he saw me and he echoed what the nephrologist at Hammersmith said, that you're a transplant patient. I told him, look, I'm being discouraged because of the risks of being old, and perhaps the nephrologist said that he could keep me alive for the next 6 to 8 years. And to die at the age of 80, I thought, well, that's long enough. I'm pretty happy with that. Sanjay Sinha gave me a lot of hope and encouragement. And then I got the nephrologist at Reading to recommend me for a transplant, and had the tests restarted. I got them done at Hammersmith and at Oxford, and got on the list on January the 12th, 2014. And I didn't think much of it. At the time, they told me that there were at least 5,000 people on the waiting list. And being 73, I thought I'd probably never get one. So I didn't bother. On May the 2nd, 2014, I got a call from Oxford asking whether I was Sujit Sen and asked me for my date of birth. At that time, in 2014, there were a lot of nuisance calls going on. And I nearly didn't pick up the phone. And when she asked me, am I Sujit Sen? I said, I wanted to know who you are. I'm not telling you. Then she told me that she's from Oxford and they think they have a kidney for me and could I come as soon as possible. I had a shock. I didn't know what to do. I was afraid because at that time, my mental state was pretty low and I couldn't decide then and there what to do. I spoke to my wife and I said, yes, I'll be coming. So we got there at 6 o'clock in the evening and I had the tests done. And a young lady doctor, I think she was doing a postgraduate work there, came and asked me whether she could have a bit of my, whatever it is that they're going to take out for her biopsy. And could I give her permission to take it, do her research? I said, fine. She calmed me down a lot regarding the transplant. Because at that time I didn't know whether I was going to get the transplant or not. Then she came back and told me, your tests were all negative. I thought, well done, I'm going home now. I didn't realize what she was trying to say. Negative meant the transplant is to go on. So nerves were there, but I was happy at the same time. And this was about 9 or 10 p.m. in the evening, May the 2nd, and I had to wait till May the 3rd, 5 o'clock in the morning before I was wheeled in. As I was being wheeled in to be anesthetized, Mr. Sinha, I didn't know he was going to operate on me. He was with a gown and cap and that. He said, I must tell you this, the kidney you're about to receive is damaged and 2 other hospitals rejected it. And Well, I was stunned. I didn't say anything. But we did a biopsy and we found there was nothing wrong with the kidneys. So they went ahead. Apparently, my wife said when I came out, I said it wasn't successful, was it? That was my first remark. However, it was very painful on May the 3rd and 4th. On the 5th of May, which was my 74th birthday, I had my last dialysis. And they said that it was quite normal to kickstart the new kidney. So that was the end of the story. And since the transplant, I've been leading a normal life. I've been around the world again. I have been doing everything possible. My energy has come back. At the moment, my wife can't keep up with my energy. And what a success story this has been. I hope this carries on for the future. Thank you very much.
Very much, Sujit. Thank you, Sean. Thank you, Phil. Very touching and very informative talks. Kidney transplantation is, of course, a fantastic success story in terms of what's achieved, and that was a perfect example of just that. We're now going to stay with the kidney. Find Mark. There it is. Good. This is now a kidney auto-transplantation. This is a service which we developed in Oxford. It's the only service of its sort in the UK, funded by the NHS. It's a collaboration between the Departments of Urology and Transplantation, and Mark's going to tell us why we do it and how well it works.
Thank you, Peter. I know they're not all medics in the audience, but just so you know what we're going to be talking about, this is a process of taking a kidney out of people, putting it on the bench, doing all the usual transplant things at that point, perfusion, cooling down. And then we started doing whatever we do, which is move between removing some very large kidney cancers, some transitional cell cancers, and sometimes some benign work. This talk is going to focus on the kidney cancers because that's been the bulk of this work that we've done over the last 16 years. And I'll go through all of this with you. So I think I'm supposed to mention this, and I do have two aspects of financial support for teaching from these two companies. So historically, if somebody turned up with a solitary kidney, or maybe even bilateral tumours large tumours in both kidneys, the option that we try and look at is removing this tumour from the kidney, something called a partial nephrectomy, and trying to leave behind enough kidney tissue to keep the patient off dialysis. But this isn't suitable for every single patient. These tumours can be quite large, quite centrally positioned, and people would feel that it's not appropriate to do a partial nephrectomy. The decision would be to take the kidney out, and obviously the patient's only got one kidney, they're going on dialysis. And this was the premise which led us to start looking at this procedure as to whether we might be able to remove some of these very large tumours and keep people off dialysis going forward. So here's just a couple of examples. Very large kidney tumours, a solitary kidney, left-hand side, both patients. Not a lot of kidney tissue looking like it's there. Tumour's quite central. And I would say most people just say we need to take this kidney out and you're going to go on dialysis. But this is the kind of cases that we started looking at the beginning of this programme. And obviously the importance of this is that if we look at the data, and I'm sorry this is not more up to date, but there are a significant number of people who have a nephrectomy end up requiring dialysis. Importantly, that graph has just started to come down from about 2012. And I think most of this was coming from partial nephrectomy work being done in a few small specialised centres. but I think the auto transplant program has contributed to this as well, which is reassuring, and it's nice to see that happening. And as many people in the audience will know, transplant dialysis is quite expensive per year. Quality of life is not great generally. There's a reasonably high mortality rate per year. And even when we've removed these kidneys with tumour in them, we have to have a disease-free period when you're not going to be eligible to go onto the transplant waiting list. And that can be anything between 2 to 5 years, depending on how aggressive these cancers are. So there's often a 7-year wait from the moment you're having that kidney removed. And I'm afraid because of the mortality rate, I believe the figures that about half of these people will not survive that time frame. So it is a problem potentially. So I'm going to show you a case, which is probably the most difficult case that we've done so far, certainly one of them. This chap, one kidney, you can see over here, nasty tumour that was actually growing down his renal vein, so actually outside of the main kidney tissue. And this guy was sent to us from around Coventry, and we had a good chat with him, and he decided he wanted us to try and go ahead with this. So we've taken the kidney out, we took it out laparoscopically, had a keyhole operation in his upper abdomen, put on the bench, and as I say, all the usual things were done. You can see the tumour there. We've taken the fat off the kidney, and quite a nasty looking tumour here on the outside of the kidney, but going centrally into the renal veins down here. So we put it on the bench, as I mentioned. Now, we were very fortunate with this chap, actually, because he had 2 renal veins, and you can see what looks like a slightly dilated structure there, and that's the tumour thrombus going down this vein, but he had a separate renal vein. So we had a quite nice get-out clause with this man if we could get this out, but he had a second renal vein that would drain, and that gave us a chance of getting this done. So a little bit more detail there. We're excising the tumour on the bench, and that's the cavity that's left behind at the end of the tumour excision. And we reconstruct that kidney, put all the kind of urinary parts of it together, and the more solid parenchymal parts. And then that is the tumour for you. And as I say, this guy was complex. He's got tumour thrombus in some segmental veins in the kidney. And this is the main thrombus growing down this main vein that we removed. So we were happy when we excised this and decided we would put it back in. And there it is, reperfused, looking like, I would say, a lot of donor kidneys look like, bar this slightly unusual area where we've obviously done this excision. And there is a post-operative CT that he had. You can see here, probably half of that man's kidney working very nicely. And he's got a stent in running down to his bladder to try and control the urinary leaks that these patients get. So here's some data for you. We've put 37 people have received an auto transplant in Oxford to date. Mixed, not surprisingly, 2 to 1 in favour of males, which is what the demographics of renal cancer are. Average age 64, but a bit of a range there. Most of these people had a solitary kidney or an effectively stable kidney with the other kidney not working. But we have done a few cases where there's been very large tumours in both kidneys, and we've taken them both out, put them on the bench, and worked on one and maybe the second to see if we could provide an auto transplant for these people. Tumour size around 6 centimetres, but quite a range there, as you can see. Not surprisingly, most of these were single tumours, but interestingly, we have taken some tumours out of some groups of people who have got genetic conditions where they've got multiple tumours in the kidney, such as something called von Hippel-Lindau disease, Birt-Hogg-Dubé, and seeing how these people got on. There's a mechanism of scoring these tumours in terms of their complexity and usually size, position, and how far they're going into the centre of the kidney is how this is driven. And not surprisingly, almost all of these were highly complex looking tumours. There's some perioperative data, long surgery, around 8 hours, but some of them have gone on for nearly 12 hours or 12 and a bit hours. Our transfusion rates presently are running at 20%. They were 35%. And cell salvage, which is a mechanism of taking the patient's blood into a system in the theatre, has been used in the last few years. And we've managed to bring this transfusion rate down to 20%, which I think is clear progress. Quite a long stay in hospital, just over 2 weeks. The reason for that is that half of these people get a urine leak. That tends to prolong their stay to some extent. The change in their kidney function, the GFR, which is what we use, is just under 20 units. I think there is an important aspect of this, that this is a surgical change in their renal function, which is a one-off hit. It happens at the time of surgery, but it's very unusual beyond that for that figure to change a great deal, though we've had a few, and maybe some conditions like diabetes, hypertension, as you would expect, has impacted on that. But the very great majority have had no change in this GFR post-operatively to the present day with their follow-up, which is important, of course. I've listed the kind of kidney subtypes there histologically, which is the expectant mix with clear cell making up the very great majority. And the stages, which is how they stage the cancer when they analyze it in the lab. They're run between T1 and T4. And I think it would probably be fair to say these were done early on in our experience. And I think in this day and age now, we probably wouldn't be doing these tumours as an auto transplant. But these two groups we would. And I think this is where we're at right now in terms of people who might be suitable to have this procedure. The further perioperative outcomes, the margin of the tumour in the kidney is looked at by the pathologists. And on 2 occasions, we've had what's called a positive margin, which makes them think that there might be tumour left behind, but they're never certain or rarely certain. But that figure of 5.6% is actually very good. If you look at all the partial nephrectomy series around the world, in somebody with 1, 2 kidneys, they're around 8% positive surgical margin. So I think we're doing a good job on that level. These kidneys often do not work post-operatively immediately, and they need a bit of supported dialysis. About half the patients, we give them 2 or 3 days of supported dialysis in those 3 days after the surgery, and then these kidneys tend to kick in and start working. One of the challenges here is that these people do get significant numbers of complications. This is a high-risk operation. You can see there 56% figure for the higher complication problems. However, a significant number of these are made up by urine leaks and changes of stents, which fulfill the criteria for 3 and 4, and maybe not as serious as some of the other complications that seen in the 3 and 4 groups. And finally, we have had a couple of deaths. They happened very early on in the program, an aspiration pneumonia and a pulmonary embolus. But in the last 11 years, we've had no deaths in this program. So we're obviously pleased about that. So here's some long-term data for you around where these people are at. Our mean follow-up now is 75 months, but we've got a patient out at 16 years. Their cancer-specific survival, 79%. Now, I've only included the T3 disease here because I think this is the group that this potential operation is going to focus on going forward. That figure of 79% is at the very highest level that you would get if you took a kidney out, even in somebody with their other kidney with T3 disease. So it absolutely looks like we're achieving the same cancer outcomes in terms of survival compared with removing the whole kidney. And likewise, these other figures here are along the same lines. They are at the higher end of outcomes for T3 disease. Interestingly, this chap here who had 2 new tumours in the same auto transplant, and I managed him as conservatively as long as I could, but unfortunately this thing kept growing, and we actually took his auto transplant out this week, which is the first auto transplant we've taken out, but it seems to have gone reasonably well. But this is a risk in people who have these genetic conditions because they are likely to make more tumours going forward. And that is a discussion you've got to have with these patients, that we might consider an auto transplant for you, but you've got to recognise you may well make more tumours in the future, and we may get to this point of having to take the auto transplant out, which is another complex operation with not insignificant risks. However, I can tell you about this man. He had a GFR of 20 when he was referred to us. It went to 18 post-op. He went back to where he came from. The nephrologist saw him, never heard of this operation, said, "Are you going to be on dialysis soon, my friend?" And he said, "Oh, well, Mr. Sullivan didn't tell me that." And 3 months went by, 6 months went by, 12 months went by, no change in this man's GFR. And eventually I got this delightful letter from the nephrologist saying, "What was this operation you did on this bloke?" I told him he'd be on dialysis in a few months' time, and we had a chat, and he was very nice and very supportive, and maybe some additional support to delivering this kind of program. But maybe most importantly, I spoke to this chap many times through this journey and said to him, "Did you really want to go through this, knowing now that you've made these new tumours?" So he got 7 years off dialysis, and he said, "I would never have changed my decision, Mark. That was a fantastic 7 years. I was able to do these things." So there we go. It's interesting how these patients see this, and they are very scared of dialysis. That is one of the messages that comes back to me repeatedly when we meet these patients. Overall survival, well, there's obviously going to be some people dying from non-cancer causes, and that's a figure that we'd expect here. And this final figure, which has also driven home our desire to continue this program, is that of all the patients who are alive with their auto, 83% of them are not requiring dialysis, which I think is a fantastic figure for these people. So there's a map of the UK and the referrals that we've got from all over the UK. One solitary referral from Scotland. Interesting. Wales actually has sent us a few cases in the last few years, but they weren't included in the cohort that I've discussed with you. But yeah, all over the UK, which is nice to see. And if you ever wanted something that might give you a great message about patient-reported outcome measures, this man with his auto-transplant used to come in our clinic with this world map, and he had these little pins on it, and he put it down in front of you every time he came in and said, yeah, I've been there since I last saw you. So he traveled all around the world with his auto-transplant. And although I know dialysis holidays happen, he certainly wouldn't have been able to achieve this on that pathway. So, you know, fantastic to see this when he came to the clinic to see us. So what have we learned over these 16 years? I think I would still ask this question about this group of people who've got multiple tumours and genetic conditions, but maybe this man who I discussed with you might make us think that we should offer it to them, accepting that they will make more tumours, but they might have a significant period off dialysis, which is what they're seeking. We do get a lot of urinary leaks. About half the patients get a urinary leak, but in my experience, they all heal up. You just got to be very patient sometimes, and we've had some people 3-4 months out. We've had to wait for this to happen. The patients do get a little bit low and depressed on it, but you have to just keep cajoling them along. And as I say, every single one has healed up in our program to date. And finally, I have to say I was quite surprised what the kidney puts up with, because this is a serious insult to these kidneys, and they survive and do their job. And it's nice to see that, considering it's not an organ that would be considered as a regenerative organ normally. So I think our conclusions right now are that this auto-transplantation is a complex procedure. It does have a high risk level attached to it, but we think it is suitable for a select group of patients. The cancer outcome data presently is very, very good. And I don't think this will change now, because we've got 5-year data, and we're probably going to have some 10-year data coming very soon. And it doesn't look like it's going to drop below those figures that would seem to be took the whole kidney out. There is no doubt that there is progression going on in partial nephrectomies, both open and robotically, and that will continue. And there is a chance that they will be able to deliver these kind of operations. We have been trying to push open partial nephrectomies more in these group of people, and anecdotally, we've had more positive margins compared with our auto-transplant. So I don't think the story is quite so clear-cut. And that case I showed you with the tumour thrombus in the renal vein, that will not be done, I don't think, as an open operation. It will require an auto-transplant to be able to do this and put the kidney back in. So, not surprisingly, there's a huge team involved with this, and quite a few of these people are here today. They all bring their brilliance to this program, and that's what matters in delivering where I think we've got to today. And lots of fantastic people here, and I just want to extend my thanks to them, because it's been quite a remarkable journey over the last 16 years delivering this program. And the final thing to say is it's an NHS commissioned program nationally. That is the only nationally commissioned program in urology in the UK. So we feel very fortunate that we've been given this opportunity, and I think we are repaying them at the moment. So thank you.
Thank you very much, Mark, and a wonderful example of innovation and the difference that it can make, and how these services can work together so effectively. We're going to change the order slightly, the reason being that Sanjay Sinha is not here at the moment, but will be shortly. So we're going to move to the pancreas, but we're going to move to islets, talking first about allotransplants and then about auto-transplants. Pleasure to introduce Paul Johnson.
Thanks very much, Peter. And I think it's a really exciting day, isn't it? Not only this morning hearing all about the really wonderful legacy and that Peter Morris left, but also seeing where that's gone on. And I think also a tribute to Peter himself, who's really put this programme in all these different areas together over the last 20 years. Yeah, great. Lovely, thank you. So I'm going to be talking about islet isolation and islet allotransplantation, past, present and future in the next 10 minutes. And I think it's really important. This guy's been mentioned a couple of times this morning, but I really want to pay a proper tribute to Derek Gray. Derek Gray, we heard that Peter Morris put together a group of outstanding people when he first set up the department, and one of those people was Derek Gray. And Derek Gray did a many number of things, but in particular, he set up the islet transplant program in Oxford, and he was a wonderful colleague. He set up some things, some initiatives. Can I have my slides back? He set up some initiatives which are now used worldwide still today, and I think he really is underestimated in terms of the tribute he's been given internationally. So I want to pay tribute to him from the beginning. And on the back of what he and Peter set up in Oxford now, our islet transplant program composes these three components: an islet isolation program, which not only delivers a national clinical allo isolation delivery. We have isolation for the Autotransplant program that you'll hear about in a moment from Mike Silva. But we also have a JDRF-funded UK research islet provision, which also goes into mainland Europe for researchers. And then we have the islet allotransplant program itself for type 1 diabetes, and we do islet transplants alone, simultaneous islet kidney, and also islet after kidney. And we're seeing an increasing number of that latter group, particularly from our Leicester clinic. For those, I'm aware it's a mixed audience, so just very briefly, islet allo transplantation is a minimally invasive procedure for type 1 diabetes, in which we just extract the 2% of the pancreas that is the endocrine component, or the hormone producing component, which of course one of the main principal hormones is insulin, which is what's deficient in type 1. So rather than giving the whole pancreas, of which 98% of the tissue is tissue that's working very well in type 1 diabetes, we just extract the tissue that's been destroyed and replace that. And the beauty about an islet transplant is it has, because it's a cellular transplant, it's not only minimally invasive, but we also have the potential to modulate the graft either by immunely isolating it, and I'll just show a couple of slides in a moment, or actually modulating the immune system in order, we hope, in due course, and I don't think we're very far away from that, as I'll show you at the end, in order to be able to ultimately give this to young children soon after diagnosis without the need for immunosuppression. And of course, that's been my whole driving force as a paediatric surgeon as to why I got into this just over 30 years ago. The history of islet transplantation in Oxford, and in fact this reflects the UK as a whole, you can see on this slide. And of course, Peter Morris and Derek Gray were instrumental in that. Peter Morris, really one of two professors of surgery, the other being Peter Bell in Leicester, who saw this as a future treatment that they wanted to put together with their other whole organ transplants. And we saw that over the 90s, there were 9 islet transplants done here in Oxford. 3 we did, I was in Leicester before I came to Oxford. And those are very much on a named patient basis. And then the big changing thing was the Edmonton Protocol in 2000. This was a steroid-free immunosuppressive regime. But more importantly than that, this was where more than one transplant was given in quick succession. So it was an islet number thing. And suddenly from 20 or 20% of patients getting significant secretion post-transplant, we were now starting to see 80 to 85 of selected patients in that group coming off insulin altogether. So it completely transformed clinical islet transplantation. And after that, you can see there's some funding. There's some key landmarks there. The first being the 2008, when we got NHS reimbursement, and Oxford was one of the centres both for isolation and transplantation. And then in 2010, a very significant initiative where our pancreas allocation system in the UK became a joint whole pancreas islet allocation scheme, which meant the quality of organs we were getting for both modalities was of equal standard. Before that, the islet programme was really getting the leftover pancreases, and not surprisingly, that was quite hard to deliver. This is the configuration of the UK programme. We have 3 islet isolation centres. We have a Scottish programme funded by the Scottish NHS. In England and Wales, Oxford and King's are the 2 isolation centres on a 1 in 2 week basis. And then the transplant centres are the isolation centres plus the other centres below. I put Bristol there because up until a couple of years ago, they were a transplanting centre, but more recently, Oxford have now been asked to take over that, and we now transplant for the whole of the Southwest as well as the centre, as the Midlands and the South. And just recently, we've been asked to take on the Royal Free waiting list as well, so coming across to North London. Human isolation is a complex time procedure. It takes about 4 to 5 hours. And therefore, this hub and spoke approach that we've developed is the right one, rather than each centre having to have an isolation centre. And the pancreases will come from anywhere in the United Kingdom into the programme. We then isolate and we'll send it out to wherever that patient is within those transplant centres. And one of the big changes over the last 20 years, as we looked at past, present and future, is that when I first started isolation back in the early 90s, we were doing that in an ordinary laboratory. We were probably eating a pizza in one hand, shaking the chamber in the other, and that's not far from the truth, because you can feel it in the middle of the night. And the regulations that have come now in the last few years with the Human Tissue Act has really transformed it into a completely different entity. And so now we have this purpose-built GMP facility, HTA licensed and highly, highly regulated. And we're very fortunate to have got a big grant from DRWF to be able to provide that. These are the different groups that we provide the human islets for research, and that again is a significant exercise, but equally each of those centres is doing a lot of pretty pioneering research on basic diabetes etiology, both type 1 and type 2. When we look at the Oxford outcomes, these are the outcomes from the Peter Morris and Derek Gray group. You can see in those, this is looking at C-peptide production or insulin production. You can see that some patients got no production at all. Some got quite good production for a various period of time, but none of those patients had significant reduction. Certainly none came off of insulin. But whereas when you look at the change, the Edmonton protocol, this shows both insulin dependence and graft survival, the green being the post-Edmonton era, and then you see the other eras before that. So this just transformed what we were doing. And in the UK, at the time we were commissioned, NICE put these requirements on us: resolution of hypoglycemia unawareness being our #1 measure, which is the main indication for this procedure at the moment, stabilization of glycemic control, and insulin independence, unlike whole pancreas grafts, was not our primary outcome measure. Although we do achieve that, that's not our primary goal. It's to achieve those other two resolutions. If we look at the UK data, you can see graft survival at 1 year on the left and 5 years at the right. And you can see that that graft survival, that mirrors the outcomes as well for hypoglycemic unawareness resolution. So we can almost uniformly reverse severe life-threatening hypoglycemia with this procedure, even if insulin dependence is not achieved. And what's more, when graft survival, when graft function has deteriorated, that persists, and the Edmonton group has shown very clearly that the benefits way outlast the function of the graft. This is the ideal outcome. You can see this is a week's worth of glucose measures on the top. You can see the preoperative huge instability, life-threatening hypos without any warnings. There have been several patients die on the waiting list because of those hypos. You can see the HbA1c, which is in the high diabetic range, and then that being reversed. And in this particular example, this patient did come off insulin, came off insulin for up to nearly 5 years. But the more important thing is the stability of the glycemia, no longer getting hypoglycemia, and more importantly, or as importantly, preventing those long-term complications that you get from getting the high sugar levels at the same time. We've also shown very clearly that the success is achieved the earlier you can get that second graft in. It's not just about total islet numbers, it's about the timing of those. And this is the recent publication showing 75% reduction in insulin requirement if you can get the second graft within 3 months. And that has been a challenge in the UK. And we've been changing algorithms of allocation to try and meet that. The outcomes of annual hypos, you can see on the left, resolution of hypo dramatically, and HbA1c stabilization on the right. That's with 24 patients in a row. One of the important things we've really emphasised in Oxford, and I think that I've really enjoyed with Sanjay Sinha particularly, and it's a shame he's not here, but basically we have gone from having separate programmes to having an integrated programme where we can offer patients a range of treatments. We can offer the most modern and up-to-date of the technology for diabetes, so the closed loop, which of course is coming in this autumn for a number of type 1 patients in this country. We can offer whole pancreas and we can offer islets. And the important thing is we tailor it to the individual patient. And we've got a number of clinics, not only here in Oxford, but also a new one in Leicester, which is run very much on this model. And so you get patients who may have a living related kidney or a living donor kidney, who then can have the maximum technology and may not need a pancreas or an islet transplant. You have other patients who have an SPK, the younger low operative risk, or maybe have an SIK. And this is, I think, really the way we're looking for the future for these programs, rather than in competition, very much working for the patient benefit. So finally, I've said that our whole aim of this is to move to children. Of course, this is where the future of the program is. And there are a number of ways of doing that, but the two I just really want to just highlight as I close is, first of all, we need a renewable source of islets, and that can either be stem cells or xenogenetic tissue, and I'm going to come to that in one moment. And the second thing is to develop immunosuppressive regimes, which are either less toxic, but ideally that are removed altogether if we're going to move this to children. Obviously, we've talked a little bit about the Treg, tolerance approaches, and of course, Fadi and myself are looking at various different options that we can try and implement that. But this was, I don't think John Todd's here anymore, but we've just recently completed a low-dose IL-2 therapy in young children soon after diagnosis. And the stimulation you get of Tregs in vivo with low-dose IL-2 also looks very promising for something we may well be able to use as an adjunct. So John is there, hi John, as an adjunct for islet transplantation in combination with maybe some other agents. But the other approach, of course, is we've got to deal with both the autoimmunity and the alloimmunity. And so the other approach is to isolate these islets from the immune system. And macrocapsules are looking also very exciting. You can put the islets within the capsule, protect from the immune system. They can secrete insulin through the pores, and yet the immune barrier is in these devices. And we've been working with this Mailpan device. This is like a portacath. You implant it a few weeks before you put the islets in. You can then get the vascularization, and then you can add the islets, and also you can flush islets in and out so that you can actually replace them once they need replacing, rather than take the whole device out. And we've also worked on this large European consortium on the so-called beta gel. This is made up of a membrane that imitates the pancreas, so it has all the same characteristics of interchange between the islets and the exocrine tissue. And we place that within a beta shell capsule. And this is very clever because it has drug eluting to it, so you can put immunosuppression into the actual device, and that can secrete for the period of engraftment. But just to close, this is really where we're talking about the future being the present. This is, I think, very timely just to put this slide up for where we are here in 2023. In September, we've just opened for recruitment for the Vertex stem cell derived islets study. The first study we're doing, the so-called 880, which is the one that's open now, is with immunosuppression. But the other one that's coming online, we hope next week, if the trust will sign it off, has got macro capsules implanted under the anterior abdominal wall on the outside of the peritoneum with stem cell derived islets. And if that second trial is successful, that is the real game changer, because not only do we have a renewable source of islets we can use any day of the week as an elective procedure, but more importantly, we can do it without immunosuppression, and then we start to see children as the domain. And I really hope in my last 8 or 9 years of professional life, I will see children in Oxford being transplanted with islets. So the future ain't what it used to be, but the past we really need to remember, and that's what we're here to celebrate today, the big strength of what we are building our current programs on. So thank you again to Peter Morris, to Derek Gray, and also to Peter Crone. So thank you very much.
Thank you very much, Paul. Very exciting times for cell transplantation, very exciting times for islets. Next, Michael Silva, colleague of mine, who is going to talk about autotransplants. That's islet transplantation, but not from different donors and for a very different indication. Mike has set up the program in Oxford. This is the most recent of our NHS-funded national programs, and it's been an area of much success and much interest. Mike.
Thank you, Peter, and afternoon, everybody. I'm delighted to be here. My goodness, considering nearly 6,000 transplants, this is a fledgling program, but I think it's fast becoming a feather in the Oxford Transplant Centre's cap, and I hope I'll be able to show you why it is so. The chronic pancreatitis is not what a surgeon would like to inherit as a specialty to treat. It's like the fibromyalgia of medicine. The patients are numerous, and most of them end up being around the age of 40, where they're most productive, and they tend to have lots of relapsing symptoms. They come into hospital, many readmissions, and as a result of that, they get fobbed off most of the time, and most of the time what happens is they get their analgesia increased, they have more opioids on board, and they end up being neglected, marginalized, and non-functioning in society. And that's a common theme when you see patients with pancreatitis. Many etiological factors that take them to this, but we are more interested in the hereditary version of it. These tend to be young patients, usually having symptoms in their childhood, misdiagnosed and then later diagnosed. And the common genes that we see are the press and the press one in the string, and sometimes the combinations of the two are commonly seen in this group of patients. There's another risk that chronic pancreatitis brings to the table, and that is pancreatic cancer. And if you look at the global incidence of pancreas cancer or PDAC in the general population, you're looking at about a 0.5% chance of an individual developing if you don't have risk factors. But if you have chronic pancreatitis, you know that there is an increased risk, and that risk keeps growing with the time you have the diagnosis or the disease happens to you. And this risk is even more heightened in the hereditary pancreatitis group, where the risk of developing pancreatic cancer is much higher than the general population, especially in the 5th and 6th decades of life. And therefore, if these patients are symptomatic, and that's important to note, carrying the genes alone is not a risk factor. You have to have the genes plus chronic pancreatitis. Then the risk factor of pancreatic cancer is very high in these patients later on in their later years. There's another group that we're interested in, and these are the familial cancer patients. There are many genes that have been implicated with them, and there are ways to suspect them. But what is known now is that these are underdiagnosed as families, and it is estimated that there's a high percentage of newly diagnosed pancreatic cancer who come from these patients who carry these risks and go unnoticed. Liverpool is doing a lot in this regard. We've got a registry, and these patients are followed up by Europanc in Liverpool, and we work with them, especially when we want their genes checked and also to see if the families are carriers. When we were putting in the bid for this service to be funded by the NHS through central funding, we did this review and looked at what the world experience was, and we could see that clearly the procedure itself, total pancreatectomy, taking the islets out of that pancreas that you've removed and putting it back into the patient, got rid of the patient's pain or symptoms in most cases, and also helped a significant proportion of them be insulin-free or help manage their diabetes much easier than if they hadn't had the transplant. In addition to that, there's a lot of experience from Minnesota, and that group has shown that those patients who have had a total pancreatectomy and alongside that an islet autotransplant had a better survival rate than those who didn't and had the total pancreatectomy on its own. So in summary, we could see that there was a clear benefit of taking the pancreas out because it took the cause of the pain out of these patients and therefore reduced symptoms and thus reduced hospital admissions, which has obviously health economics implications there clearly. And in addition to that, these patients could reintegrate and function back in society and therefore be more productive towards society as well. Importantly, no increased morbidity or mortality related to the operation itself. We got commissioning in 2018, and there were 4 other 3 other centres alongside us who have been commissioned to carry out this procedure across the Scottish border. Edinburgh does do it, but they haven't got commissioning for this. And although Peter Friend and I were involved with the bid for the commissioning, I think we cannot not mention Ashley Denison, who pioneered this whole process in the UK and had at that stage done the highest number of these procedures. If not for Ashley, I think we wouldn't have got over the line to get this procedure commissioned. So thank you, Ashley, for that. So what are the indications for this procedure? It's for patients. It's a subset of patients. It's not for everybody who's got chronic pancreatitis. It's a set of patients where we failed all non-interventional and interventional measures. And we're looking at patients who've had endoscopic procedures, who've had surgical decompression, and in addition to that, celiac plexus blocks and lots of opioids as treatment. But what we want is to make sure that we're offering it to patients where this is actually impacting their quality of life. If we're looking at a kid, if the kid's not going to school half the year, if you can't go to work most of the days of the year, then that's the question that we would like to help. And it's recurring attacks in a younger population. Obviously, there's no question if you have this as a diagnosis, they get priority in care. And as a consortium, when we meet, we do that quarterly now with the other centres. We are now emphasizing the need for centres to refer patients to us prior to considering decompression, because we know that if you decompress, you end up with a worse outcome when it comes to the islet function post-op. We also tell referring centres not to send these patients to us. If you are already insulin dependent, there's no need for them to come to us. You can have a total pancreatectomy, yes, but there's no islets to put back in that'll be functional. If you've got peripancreatic collections or huge necrosis of the gland, then again, it won't be functional or possible surgically to do the operation. And if you've got other issues that cannot be sorted, if you've got complex psychosocial issues, this is a patient who's now very likely going to be diabetic and needs to be able to control their diabetes to an extent. You need to have a stable lifestyle, and obviously you need to be fit enough for the operation. What are the objectives? The clear objective is not the islet autotransplant. The objective is to relieve the patient of the intractable chronic pain that they have that makes them unable to function normally. And that's the clear indication, and that's the main indication why we do it. And it is to help them return to society as a well-integrated individual. And at the same time, as an adjunct to that, by doing the autotransplant, we can achieve better glycemic control. And that's the clear distinction that has to be made with the patients as well as the family. So how do we assess these patients? The referrals come to us, and I work very closely with Jenny Fox, who's our PPIT CNS, and I vet the letters, and then we would go through an assessment program that essentially is 3 phases. Before we see the patient for the initial chat, Jenny will send out a questionnaire booklet informing them what the procedure is, what the assessment is like, and also a quality of life assessment is sent to them. And the initial review would have a surgical review, hopefully with someone who's supportive and understands what we're discussing. And Jenny plays a very big part in these interactions that we have. So we assess whether the story fits, whether the patient has chronic pancreatitis and it is plausible that this might be helpful, and also whether the performance status would be such that the patient will go through the assessment process. The second phase is for us to confirm that actually there is objective evidence of chronic pancreatitis. We've had patients who've been for years treated in other centers, other tertiary centers, and called or labeled to be chronic pancreatitis. When we look at the scans, there is no evidence of such. And then it becomes a big problem for us to change the agenda and tell them, look, your pain's due to something else. But that's an important aspect, and also to see if there's any anatomical or surgical reasons why we can't offer the procedure. And at the same time, in parallel, we'll work with the diabetologist. So Alistair Lambert leads that group at Optem, along with the Islet team, where we do a meal tolerance test and check C-peptide levels to assess whether they have adequate islet load to be able to have the procedure done. The third phase is where we re-evaluate everything, make sure that we're still on the same page and we understand that the patient actually needs the procedure. And at the same time, they go through an MDT process where they see a chronic pain specialist, a psychiatrist, not to see if they've got a sound mind, but just to see if they have the right expectations and to also manage the expectations in the post-operative period. If needed, they'll have a gastroenterological or a specialist dietetic review. Once we've had that, and this whole process takes about 3 to 4 months, we'll have an MDT where we will discuss and have a list, and any member of the MDT can veto listing just like others. The operation itself is a bit more challenging than would be a standard pancreatectomy, simply because of the fibrosis and the additions and changes around. But essentially what we do is we remove the pancreas along with the bile duct and gallbladder. Most of the time we'll try and preserve the spleen for obvious reasons. The pancreas that comes out looks very much like this. It feels like a bit of wood, really, rather than a normal gland, because it's so fibrous and diseased. And it's shocking sometimes to even expect that this has any functional cells in it that will then be autotransplanted, but it does. And once we've handed over that organ to the Islet team to go and isolate the islet cells, what we do is, so that's the liver, and that's a round ligament, which we recanalize the umbilical vein and stick a cannula in. It's a 3-way, which has a triple lumen, one of it for flushing, one of it to assess the portal pressures, which we measure real time, and the other to infuse the islets through, and also we monitor that real time with ultrasound. It was already discussed how the islet isolation happens, and at the time that's happening, we do the reconstruction, so the patient is then ready, waiting for the islets to be put in. And it's actually, for me, it was actually shocking to look at this for the first time. You see this slurry-like substance, which are the islets, going into this lovely liver. To me, with a liver surgeon, who obviously thinks that the liver is the most sacred organ in the body, this seems like sacrilege to send this amount of slurry into this liver. And it's even more scary when you see what it looks like in real time, where you can actually see it going into the portal system there and lodging in. And you wonder how it doesn't cause a lot of thrombosis and mess the whole liver up, but it doesn't. So the post-operative period is usually in the Churchill or overnight recovery, rarely to ITU. We have excellent support from the diabetic team. It is a joint post-operative care. We have chronic pain input, and also we have close monitoring of function, as well as making sure the patient doesn't have thrombosis. A quick run through of what our results are thus far. We've had 48 referrals, and of which we've turned on 21, listed 30, and we've done 24 procedures. These figures are from last year. We've not updated this year, but just to give you an idea of what the mix of patients are like, they're usually young. Usually lots of them, all of them are on shed loads of opioids, and a lot of them unable to work. Average duration of the operation, you have to subtract about 3.5 hours, which is for the islet isolation. We stand down during that time, and we've had to do a few other additional procedures alongside this. And the longer term outcomes, you can see clearly that the patient's opioid need have come down, as has the requirement for analgesia. But more significantly, almost all of them have had complete resolution of the pancreatic pain, which is a great thing, really. The program cannot happen without a team. Jenny is actually the kingpin. She's the glue that keeps all of us together and in check and make sure that everything works for us. Alistair Lam, who is our diabetologist, Paul, as you know, Zihan as our psychiatrist, and Tim McCormick, our pain specialist, and David Horsworth, our anesthetist. Thank you.
Thank you very much. Welcome back. Hope you've enjoyed the tea. We're running some little while late at the moment, so apologies for that. We are therefore going to finish a little late. Who we're going to hear from now is Sanjay Sinha, who's been a stalwart central figure at the Oxford Transplant Centre for a long time now, and he is going to tell us about solid organ pancreas transplantation.
Thank you, Peter. It's great to see so many familiar faces. My apologies to Carol Bradford, Peter Friend, and everyone actually for being truant and not being here on time. It wasn't particularly my fault, but we'll not go into it. How do you move the slides? Oh, right. Oh, this one is it. I mean, you'll be relieved to, I mean, there have been some fantastic talks. I've only heard Paul Johnson and Mike Silva speak. My talk would be different, actually. I didn't have a talk. I was in London this morning. I actually drove back to London because I became a grandfather this year, and I'm absolutely in love with my newfound cherished role. My wife and I are in love again, but with a grandchild. So I drove myself back to London, and that's where I live actually. And I work from home from London, although most people know this. So Rainer Buehler is here, Director of Operations. I saw him. Oh, there he is. Rainer, I do work, but it's from London. So yeah, then I've Ubered myself back. I was actually planning to do this extempo. Peter, I'll not run over, so don't you worry. But then I thought maybe, you know, we've got foreign guests. I can see Bob Montgomery at the back, and at least he would like to see a few slides. So back in the Uber, I did some slides. I had to do the hotspot connection with my phone to get a few pictures from the internet. I managed that. So, you know, although I turned 60 this year, I'm doing okay. Right. This is absolutely fabulous, and I love this story. And you know, we've had this morning celebrating the life of the late Professor Sir Peter Morris. And you know, what you leave in life is really important. And one of the pivotal things that Peter Morris did was in 1999, he got a tall, strapling chap from another university town to come to this town. He actually looks pretty similar. He did say some nice things about me at the beginning, so this is just paying you back, Peter. But actually, you know, you get a young man with ambition, with drive, with tenacity, and you can go on and describe a lot of things for Peter. I'm sorry you still haven't had a knighthood, but we need to put in the recommendation for that. He deserves one. So this young man came across from another university town with a slightly prettier looking river, and set stall here and started the story. I'm married to an obstetrician, and we often have discussion who does the better job. My wife is part of the process of life. My job is not quite similar, but I do give people a second innings in life at least. So, you know, but in that conversation on the on the dining table, I said, darling, you've got a better job. But you know, I do a fairly good job too. So, but like most things, you'll be delighted to hear that pancreas transplant was also born in this city in the maternity unit or the women's center, Peter, as you would say, because nobody would let Professor Friend operate anywhere else. So he said, fine, pancreas transplantation will be born in the women's center at the John Radcliffe. And he had a friendly anesthetist, and that's how it started. Peter did pretty badly to begin with, to be honest. You know, if this was today's world with clinical governance and all the rest of it. By the way, I do lead clinical governance for the country. So Peter, you would have had a tough time. So out of the first 10 Peter did, 5 didn't work. I mean, they all did well. They all had a kidney transplant. So when I go and tell other people about starting new programs, I always cite Peter Friend. You know, he had friends, and so they let him continue. Most other people would have had to stop. You have a 50% success rate for a new procedure. You wouldn't be allowed to proceed. But anyway, Peter started it, and in 2004, the NHS commissioned this as a service. You've heard about commissioned services. So we do get money when we do this, and Rainer Buehler is happy when we do it because his coffers are ringing. The other thing which good people do, and you know, we've heard a lot about Peter Morris, is that you get a good team. And you know, I have a former mentor of mine, Bob Sells here, so I'm delighted to see Professor Sells. And you know, good people recognize talent. So Peter Friend got hold of a urologist who was also a transplant surgeon to work for him. He was working in the States. He didn't have a visa to carry on working in the States. People in the States are funny sometimes, Bob, sorry about that. So the poor chap had to come out of that country to get back into that country. So Peter Friend saw this is an opportunity, and they set stall, and the rest is history. So they went on their bike all over the country, going and setting up these peripheral clinics, etc. And slowly the work started. So that 50% success rate started improving. By 2006, we had done our 50th transplant. So it took us 4 years to get there. And we did open a bottle of wine in your kitchen in Parktown. We just got a posh house there. And so the story started. I mean, there were sleepless nights and we were doing back-to-back transplants. You wouldn't believe it. The Churchill Hospital is a unique hospital. Till about 2008, they didn't have an intensive care. So we had to go to the John Radcliffe. And there have been occasions when I've actually taken the patient in my car and driven them to the Churchill, because that would get us into theater. I mean, thankfully, we don't have any colorectal surgeons here, but I've been abused by them because, you know, we get into theater and just don't come out of it. So the program grew. And I know Chris Watson is here. Sorry, Chris, but we do beat you hands down on this one. I will go for my kidney transplant to Cambridge, no doubt. Till about 2 years ago, when their waiting list was the shortest, now ours is the shortest in the country. Anyway, you can see the exponential rise in that. And some of that coincided with Peter appointing me too. Right? So that's how it grows. And for a few years, we were the biggest center. You know, Bob, we were beating Madison, we were beating Minneapolis hands down. And then we sort of stuttered a little bit. And then, of course, the pandemic came, and that's where my slide ended. But that's how things moved on. We did many firsts here. We actually did not insist on the patients coming to Oxford. We set up peripheral clinics. We still go to Plymouth, and tell you what, you go there to see 4 or 5 patients, but it's a 3.5-hour journey each way. It's a long haul. And we've got clinics like that spread all over. The patients love it. But what Peter also did was actually handed the reins of running the service to our specialist nurses. And some of them are in the room today. And can I just thank them because they are the absolute stalwarts of the show. I know Mike Silva thanked Jenny Fox, but we got we got Simon Northover and Terry Morgan here and Kim, who was briefly with us, and they do a stellar job. We've lost a lot of friends along the way, and Oliver Ormerod, a cardiology friend, very dear friend, he with Peter started doing a cardiology MDT in his office. Oliver, workaholic that he was, would always be in his blues in between his angios. And that's how it started. And Nick Sabaval is here in the room. And that transplant cardiology meeting, which is now joined by our anesthetic colleagues, and I see Sean and Peter Dimitrov, it's been absolutely stellar. Bob, you'll be surprised to know we take pretty high-risk patients, and our incidence of peri-op myocardial events is very minimal. It's less than 1%. And some of our patients, you would say, are you mad to us? I do apologize, I shouldn't say that. But you know what I mean, is that pretty high-risk patients. We also did the first deceased cardiac donors, for those who understand that kind of science, pediatric organs. And I used to get bored when I was a bit younger, so I used to drag Peter, we can do this operation differently. So we did try some lap-assisted pancreas transplants. Rainer, you never let me do the robotic surgery when I first wanted to do it in 2016. I'm older now, and I actually do not have the patience to sit on the console and get my 200 hours. So, but I think pancreas transplant for the younger colleagues in the room would lend itself really well to robotic surgery. Right. Is my time run out? Not yet. Okay. So I put this picture up primarily because in 2019, some of you would recognize it. It's Madison, Wisconsin, the medical center there, and the one in Minneapolis. We also did 1,000 pancreas transplant, the only center in Europe and the only center outside of America to have achieved that. That's a major milestone, and we're very proud of it. So I was up all night, and I did the 1,153rd pancreas transplant this morning. And Peter, it was supposed to be back-to-back SPKs. I don't know, my fairy godmother or someone did say the pancreas wasn't that good, so I thought I could sneak away at 6:30 in the morning. Otherwise, I probably would not have been here, Suzanne, and I'm sorry that I've spoiled your program. You're supposed to go a lot earlier. Right, but we couldn't have done this without our donors. And of course, we couldn't have done this without our patients. And a lot of them are here today, Caroline, Sarah, and Suzanne and others, because you have reposed your confidence in us. And with you, we have learned and improved and try to continue improving, and we'll continue improving. And I've got younger colleagues in the audience who will continue to do that so that we can continue doing the best for you. Right, that's a long list of people who've all been involved. I'm sorry I've not thanked everyone. I've named every surgeon who's ever done a transplant in Oxford and pretty much everyone else. So I won't bore you anymore. Thank you very much. Right, and Suzanne, without further ado, can I please invite you to the podium? Suzanne Schneider, please. She's one of our patients, and she is going to talk to you about her experience, but more importantly, she's done a PhD.
Currently completing.
Currently completing. So Suzanne, the floor is yours a bit later.
Thank you. I didn't want to compete with any medical slides, and my interpretive dance isn't that good. So I'm going to tell you my lived experience through the medium of poem. I actually wrote a poem a year after I had received my transplant, and I was fortunate enough to have it published on the Transplant Games website. So it's called Waiting for the Call, and it's all about the experience of being on dialysis. So it goes something like this, which is, I'm oh gosh, I forgot to remember my first line. So I'm nervous and weak, washed out and sore. Oh gosh, I'm completely nervous right now. My self-esteem is down on the floor. I've been told I can't eat the yogurt, the cheese, or the toast. No coffee, no chocolate, no Sunday roast. Like an animal in a zoo, I'm attached to my chain, waiting for this dialysis machine to drain. My appetite's gone and I'm uninspired. I feel grey and grumpy and I'm always tired. There's no random trips for coffee with a friend. This is the new reality I have to contend. There's too many digestives and not enough tea. This restrictive diet is killing me. I'm weighed at the door to check my fluid intake. That blood pressure reading must be a mistake. Potassium, phosphate, protein, and sodium, if they're out of range, there'll be pandemonium. I've been shown my normal treatment seat for the night. 4 hours of sitting here, no end in sight. The machine's connected, there's no getting away. I need this dialysis to get through today. Suddenly there's an alarm and I wake with a shock. It's nothing, it's just a tube with a block. I sometimes wonder how I got to this point. I'm a prisoner held at ransom, my life at gunpoint. I spend my time, writing my new bucket list. Only now there's a small but fairly significant twist. I'm not asking for a trip to Rome or Sicily. Instead, I'm asking for a stranger to rescue me. I've never met you before and I don't know who you are, but will you be my life-saving organ donor? 7 calls from Oxford and still no find, and every day was a struggle to keep a positive frame of mind. And then something happened and it changed everything. It was 31 March 2016. No time to worry, to think, or to pray. I knew when I woke up it would be a new day. Without my organ donor, there would be no story, no message of hope, salvation, or glory. This poem is dedicated to her generous heart for turning sorrow to hope when she had to depart. So, sorry, that was a bit of a nervous rendition of the story. I can honestly say my life has changed from, continual what felt like nights to what is really brightened to many more happy days. I've been lucky enough to start, I've been working full time for the past 7 years. I currently manage a global program and I study on the side. I'm currently doing a PhD at Warwick Medical School, particularly researching the impact of the ketogenic diet in type 1 diabetes, to see whether that could be helpful for people with type 1, hopefully avoid the journey that I've been on. I just wanted to take the opportunity today to thank 3 specific people. And they are definitely, I consider them to be in this room, certainly. The first is my donor. Without her, this would not have been possible. And every day that I'm allowed to drink as much coffee and tea as I want, I thank her so much. For anyone who's ever been on a fluid restriction, you'll know what that means. The second person is Dr. Sinha. Honestly, without your genius and your kindness and the way that you and your team helped make the journey a lot easier is really commendable. And I'm so grateful to you. Thank you. And the third person is Dr. Sean Scott. This is an incredible story, but I had done my master's degree in nutrition and behavior, and I had said on Twitter one day, oh, I'm kind of nervous. I'm going to be presenting my thesis to the exam board. And some crazy person wrote back on Twitter and said, oh, I'd be really interested to read this. And I thought, who reads somebody else's thesis for fun? And it was Dr. Scott. And And after reading it, it was all about my lived experience of being a patient on dialysis and what it's like to have such a restrictive diet. And he encouraged me to take that further, and I was fortunate enough to present it at the Insulin 100 conference, which was in recognition of the discovery of insulin at the University of Toronto. And he wasn't going to let me off the hook. After I'd done that, he got in touch again on Twitter and said, well, what are you going to do now? And I think it was a bit of imposter syndrome, but just having somebody external to your inner circle who pays attention and says, I believe in you, you know, gave me the confidence to say, well, actually, if somebody else believes in me, maybe I can actually do this. And so I was inspired to apply for the PhD, which I'm currently doing, and I've just started my 3rd year, so watch the space. And I thank you, Sean, for all you've done. I hand over to next, but I appreciate the opportunity. Thank you.
Thank you very much, Suzanne. That was wonderful, very, very powerful, very meaningful. Thank you. We're going to change organs now. We're going to move to the intestine, and it's a huge pleasure to introduce my colleague Srikanth. Reddy. Srikanth's been with us for 20 years, I think, young boy. Leading this exciting intestinal and multivisceral program. Now we were hoping to have one of our patients with us, but I'm not sure I can see him. Is Adam here? In which case we're going to be doing this without a patient, which is a shame, but never mind. Srikanth, over to you.
Yeah.
Thanks, Peter. While I was putting the slides up this morning, my wife, she's not a medic, she looked at these pictures and said, oh, they're not too gruesome, and it almost looks like a crime scene. But in my house, I can put everything down to Prof. Friend. I said, Prof. Friend lent me the slides. So my very junior doctor days, if I had to hang out in the pub late in the evening, if my wife called, why are you not at home? I'm with Professor Friend, and okay, I'm excused. Of course, when you can we can convert from something like that to something like this, it is a miracle. Certainly, that's something that always impresses the medical students or anesthetists or whoever is watching the operation theater. So intestinal transplant, it's perhaps one of the last frontiers. That's what we thought till, of course, Prof. Montgomery showed that actually restarting a new frontier in transplantation with xenotransplantation, where we'll perhaps go through some of these challenges again as a transplant community. So there are a range of surgical options. So of course, you can have a very straightforward, what is called an isolated small bowel transplant, which can take anywhere between 7 to 8 hours, to a full multivisceral, which can take up to 15 hours. So unlike kidney transplantation, where results are very good, it's a long way to go in terms of intestinal transplantation, because the window between actually most of our transplant patients walk a narrow path, in the sense on one side they can fall into rejection, other side they can get infections. Unfortunately, that window is much larger for liver transplant patients, and it's much narrower for our intestinal transplant patients. So that's where the results perhaps are not as good as we are achieving for kidney and liver transplantation. So it's now a commissioned service, and in fact, undoubtedly, UK is a leader in Europe in terms of intestinal transplantation. I think there's no dispute about that. We do the most number of transplants. Both Oxford and Cambridge, we take referrals from around Europe in countries, even other developed countries, OECD, 7 countries where they don't have access to intestinal transplantation. I'll just, in the interest of time, I'll go through. So there is, of course, this is the unit which has been run by two Peters till now, Peter Morris and now next Peter Friend. And of course, Peter Morris had an impact on intestinal transplantation. We know that actually all the principles that have been developed for kidney transplantation, like cross-match, antibodies, rejection, they all actually are more relevant to intestinal transplantation than even kidney transplantation. And of course, I think Roy Khan did the first intestinal transplantation in UK. And of course, some of the principles of tissue typing laid down by Prof. Morris have been relevant to this transplant type. So I think we got to thank both the pioneers, two of the father figures of transplant surgery in this country. And of course, in terms of the journey in Oxford, of course, it's our patients. This is a photograph of our patients in transplant games. They are the ones. None of us would exist if not for the patients. We exist only because of the patients, and it's not the other way around. The patients don't exist because of us. So we should remember all that. And of course, Mr. Sinha showed a photo. This is a more dashing photo of Peter. So essentially, I made it. So Prof. Friend brought the Cambridge surgical brow order to Oxford. Means, of course, Prof. Morris was actually more a scientist, and of course, Roy Khan was somebody who went for it. And I think Peter perhaps combined the best of both in Oxford, carrying on both the legacies, the legacy of Roy Khan in Cambridge and Peter Morris in Oxford. So what it meant is we're always prepared to take the dive into unknown, where there is a risk. And in fact, Michael Mosley, some of you who watch BBC, is a presenter who picks up on some of the important developments in medicine. And he said surgery only advanced because there were surgeons who were prepared to fail. If we wanted 100% success, then we would not do anything new. I think in a way, the journey into intestinal transplantation, even in Oxford, has been a bit of a dive into unknown. And of course, there was this handsome, dashing surgeon whom Peter had recruited, who was there with Peter in the initial parts of the journey. And of course, the current stewards of the program are our nurse practitioners, Kim and Pedro. I think without Kim and Pedro, this program wouldn't exist. Means we can always find a different surgeon, but it's hard to find somebody who is 100% committed to intestinal transplantation, which is Kim and Pedro. We have initiated the program in 2008 and 9, and Mr. Sinha confused me with the figures. He said we've done 50 intestinal transplants. I think what he meant was 50 isolated small bowels. I think this morning, Dr. Mason put up the correct figures. We've done 67 intestinal transplants. This one coming up. How can I get rid of that? This button.
Oh, that's on the
yeah. Yeah. Thank you. Okay? Yeah, thank you. It's for the person. So it is patient-centered and driven. Means it's not often we get a photo of a patient accepted in a medical journal. This is Stephen Prescott. So I'm not going to talk everything about how we do an intestinal transplant. I'm going to touch on how the legacy of Peter Morris and then, of course, Peter Friend carries on in the unit. Some of the innovations that Oxford has contributed to the world. Means Peter Morris, Prof. Morris is a good example. When I joined as a core trainee, very, very junior doctor, for those of you who don't understand the grades, we did only about 70 intestinal kidney transplants. It was not a large number. There were centers doing 500 in Brazil, perhaps 1,000 in Iran. But actually what Prof. Morris did was actually you can do exceptional science, and that 70 patients perhaps made a difference to 7 million patients worldwide with what he discovered and invented and seeded in the rest of the world. In a way, that is some of the legacy that's carrying on. I think we can't impress with the numbers because the numbers are small, 67. So Stephen Prescott was a patient. He was an international rugby league player, and he had an end-stage condition called pseudomyxoma, which is usually fatal and people die in a terrible way. And he said that I'm not going to get defeated by this cancer. So he read about intestinal transplantation and came down to Oxford and met Anil and Peter, and then said, I want to have this procedure which borders on being experimental. So here you can see a horrible fungating tumor. And then, of course, the CT scan, the tummy full of cancer. And of course, so it's like the solution was bold, direct, surgical. And this is actually two brilliant surgeons, perhaps since Sugar Baker has retired in America, perhaps the two best surgeons in the world in their area, which we are lucky to work with, where they removed the cancer along with the Oxford team. And that is how the abdomen looks like. And then we transplanted. So the other challenge with intestinal transplantation is, so that's the first time that has been done in the world, and that has since been published in the literature, showing that it can be effective in highly selected patients. And then the next one is, of course, one of the challenges of intestinal transplantation is closing the abdomen and the scarred abdomen. And we're also lucky to work with another brilliant surgeon, perhaps one of the best surgeons in this area in the world, a highly talented surgeon, Hank Gill, in terms of abdominal wall transplantation, and showing that you can achieve closure of the abdomen, even in highly complex patients, using surgical skills. And of course, this is a paper that was accepted earlier this year in Annals of Surgery, where we showed that for a condition which was fatal within 6 to 12 months in the majority of the patients, we can achieve up to 50% 5-year survival for a cancer. I'm a pancreatic cancer surgeon on a day-to-day basis, apart from doing transplantation. And I know that we're not able to match that survival in pancreatic cancer this day with the combination of the state-of-the-art chemotherapy and surgery. So that's something which Oxford can be proud of. And of course, this is us showing that we should be carrying on with the legacy. It's a responsibility for us who are working in the unit that actually we had to carry on with the legacy of Peter Morris. And of course, Phil Allen, one of our consultant gastroenterologists, was one of the first to show that actually quality of life is improved after intestinal transplantation compared to before transplantation, or patients who are struggling on parenteral nutrition. And that was also published in a peer-reviewed journal. One of the other innovations here, again, conceived by Anil and then executed under the stewardship of Peter, but Hank, is that actually from a patient who is having an organ transplant, a solid organ transplant in the abdomen, if you brought a piece of skin from elsewhere and transplanted in the forearm, then the patients can perhaps look on a daily basis and make sure there's no rejection, because rejection manifests in the form of a rash. And this is something which could be helpful in organs where rejection can be difficult to diagnose. Or if patients live very far, the patient is living in Northern Ireland, and it's hard to get to a transplant unit, which is in Oxford or Cambridge, so a patient can look at the forearm, and Henk is exploring that further trials. So small numbers, but sort of thing, again, legacy of Peter Morris, where you innovate, and then of course you try to rigorously evaluate it, incorporate other transplant centers, because you don't have the volumes to try to help establish that evidence that is required. So intestinal transplant is hard work. It's only a small, I think we do 5 or 6 a year. Peter and Anil used to do all of them. And after, of course, Anil retired. And the first one I had to do on my own. Peter was in holiday in Greece. And I said, Peter, can I take a flight back? There's a transplant this afternoon. And Peter said he can't come back. I don't know whether I believe in God or not, but that is the perhaps first time I prayed in a long time. God, I need you on my team. And fortunately, it went well. And the patient was really grateful. So patients ask me, why do you do it? Patients and my fellow professionals, it's really hard. Why don't you stick to something easier, like doing kidney transplants or doing your Whipple? But it is like that. It's hard work, but when you see it all coming together and patient recovers and is well, then you know it's worth it. It's like I took my son, of course, he always used to be the lone Indian boy who used to play rugby for many years. So good for equality and diversity for the club. So when the try happens, it was hard, it was brutal, kids crying, but it was worth it for the team. It is a bit like that for intestinal transplantation. So this is a slide that was lent to me by Emilio. He's one of our new consultants. Of course, in the spirit of Peter Morris, we found that there's this young, dashing, talented surgeon from Holland working in Belgium who is interested in intestinal transplantation. And Peter was quick to spot that, and we have brought him across. And currently, unlike kidney transplantation, intestinal transplantation is like that. You're walking a tightrope. But hopefully one day it'll be like that. And hopefully before I retire. And this is a photo of my children. So when they're small and when they actually wanted to hang out with me and said, Daddy, let's go into the forest. So I used to take them here. And when they wanted to walk, I said, gosh, if they fall, is my wife going to be screaming at me? But now as they've grown bigger, that's intestinal transplantation now. And of course, as they got bigger, now they don't want to hang out with me anymore, but we know that they're in a safe space. So hopefully that's where we're hoping to go in the future.
Srikanth, thank you very much indeed. That's a wonderful overview of what is actually rather a difficult process altogether. And now we're going to move on to our most recent transplant surgical adventure, which is a new program which has been led by Isabel Quiroga, and I'm looking forward to hearing all about it.
Thank you. Well, thank you very much. It's hard act to follow. Everybody's been amazing, and I hope that you're enjoying the day. This is the last program that we'll present today. Thank you very much. So this is the last one that we've introduced in Oxford. It is a very strong collaboration, it's just not Oxford, but this is the work of two major institutions, Oxford Transplant Centre and the Imperial College London. The whole story of uterine transplantation in the UK started about 25 years ago, led by Richard Smith in Imperial College. But he reached out to us about 9 years ago, and the journey started with us. There's other organizations also involved, and we have the Lister Hospital where the patients get the IVF program, and Wound Transplant UK, which is our charity that are funders of the program, because as yet is not funded or commissioned at all. So uterine transplantation is the new option, and possibly the new reality for women that have absolute uterine factor infertility. Those are women that are either born without a uterus or have a uterus that is non-functioning. And there's this condition with a very long, complicated name, but for short, it's MRKH. And these are women that are born, it's about 1 in 5,000 women born in the UK without a uterus. So they are phenotypically women, they have ovaries, they go through puberty, but then they don't have periods. And just with a single scan one day, when they have that scan and they're told that they don't have a uterus, their whole life changes in 1 second. And actually, I admit, I wasn't very taken by the program initially until I met the first woman, until you start meeting women and how their lives is totally destroyed by this diagnosis. And to date, about 80% of the transplants that have been done in the world come from MRKH patients, but also the patients that might have had a hysterectomy, maybe due to cancer or bleeding, would have absolute uterine infertility. And finally, this condition, Asherman's, in which is a scar uterus. They do have the uterus, but it's so scar that they will not be able to conceive. And uterus transplantation would be the only option that will give women the opportunity to experience pregnancy. The other option that these women have, and many would choose that, would be either to go through surrogacy, which is illegal in many countries in the world, is not accepted by some religious, but also in the UK, for instance, legal mother of a child is the woman that gives birth to that child. The other option that they might have is adoption, but of course this will not be related, genetically related children, and it's quite uncertain of that route of when they're going to have a child. So when we do in uterus transplantation, we would get the uterus from a donor with a small cuff of vagina, and by joining the vessels from the donor to the recipient, then they'll get the blood supply from it. What we do not do is transplant the ovaries, and therefore from the donor, and therefore there's absolutely no chance that a child born after a uterus transplant will be genetically related to the donor. We can do living and deceased donors, and for everybody to agree, the aim of uterus transplantation is to achieve the birth of a healthy, genetically related baby. It's not just to fill as a woman, or is not to fill a period, although they do have periods. And the story so far across the world, there've been around 100 transplants. It's difficult, both from living donor and deceased, very difficult to know exactly how many there have been around the world, because the reporting, or we still have not agreed of how do we report, how do we collect all the cases. There have been, the first case was done in successful case was done in Sweden in 2014. A baby boy was born, and he will be 10 next year. And there's been another transplants across the world. To this day, we have around 40 children that have been born. All of them so far are healthy, with no abnormalities reported today. But the worrying side, and probably this is because it's a very early, very young procedure, is that the surgical success is only 75%, which means 25% of grafts will fail within the first week or two. And I remember clearly talking to Professor Friend multiple times, and every time we discuss about the uterus transplant, he would say, Isabel, this will work. This has to work. And it's like, failure is not an option, no stress or no pressure there. But anyway, the good thing on the other hand is that once that you achieve a surgical successful transplant, the live birth rate of a successful transplant is enormous, about 80%, which is way over any IVF procedure. So what women go through, first of all, we find out whether they are suitable. Then they have to go through an IVF procedure to make sure that they don't have ovarian infertility either. Once they have good embryos, then we could proceed with a uterus transplant. Then they have a change or modification, their immunosuppression before the embryo transfer. Once that we feel that they are healthy and the graft is doing well, they will have the embryo transfer, hopefully a healthy pregnancy, followed by a delivery by cesarean section. And once the family is complete, the patient will have a hysterectomy. Yet again, we want to minimize the length of time that the patient is immunosuppressed to prevent complications. So we in Oxford have two programs. We have a living donor program, and we have a disease program, which is still in the research form. And this is a study called the In Situ study. The main sponsors of the study are Imperial College London and Oxford. And as I was saying, it is fully funded by Wound Transplant UK through donations from the public. And we have ethics approval for 10 transplants from DVD donors. So we had the ethics approval in 2014 and further multiple resubmissions, because this was taking much longer than we were anticipated. And so when we went in, when we started with them, we had to go through a huge process to make sure everybody was on board with us. So we've gone through all sorts of bodies to get this approved. A huge partner here is NHSBT, the Human Tissue Authority, and our donation partners. And in OUH, we have gone through a huge amount of discussion of whether this was the whole thing, and we've got all the agreements all through the years. And then we were about to do our first living donor transplant when the pandemic hit us, and we had to suspend the program. But after that, we then regrouped, and we went live in 2021-22. And we did our first transplant. This was a living donor transplant in Oxford in February, and this was the first UK transplant. There's only one program in the UK, which was based here. It was a living donor from a sister to a sister. We decided to do it on a Sunday to minimize the impact on the NHS services. We are very mindful that the NHS is going through very difficult times, and we certainly didn't want to add to the stress or the stress that we're going through. All the medical staff and many of the other supporting staff did this work with pro bono, of course. And all in all, we have about over 30 people working on that Sunday. And we had to bring this photo with everybody. This is the WHO after we had the breakfast first thing in the morning. And the one person that has not been mentioned yet is Mr. Udupa, who happens to be one of the surgeons, one of my colleagues that contributes to every single service, every single transplant program he's involved with. And then we have also Anna Bermudia, which is one of our registrars who was part of our transplant program or team. So in the way this works is that the Imperial College team, gynecologists, they did the donor hysterectomy and our supervision to make sure that all our vessels were healthy. Then we proceeded mainly with the Oxford team, transplant team, we proceeded to do the transplant. It was a very challenging procedure, there's no doubt, a very stressful day, but at the end, everything went very, very well. We had I think we looked much happier there. This is at 5:30 in the morning. We look much happier than in the morning, in the previous day in the morning. We finished on the Monday morning. And this was the whole team that stayed behind. And we're very, very grateful to everybody that contributed. So after the operation, both patients recovered very well. The donor was sent home on day 5. The recipient was discharged at day 10. And they remain very well and hopeful that we will have a baby. We're planning on proceeding with embryo transfer either in November or January, depending on the logistics. And we kept this all very quiet until we decided that we needed to make it public because we needed to tell our patients to come what had happened. And we just had a press release. And after the press release, to our surprise, we were all over. We made front news everywhere, and every paper had us on the front page. We were all over the news for over a day, and it was only the India landing on the moon that trumped us to the second news. So I have to say, so that's Richard Smith, my collaborator. The most stressful thing, I think it was being interviewed by the Today program live, and that was like, you know, thank God that John Hafrins has retired. So what next after this? It was a massive press, a lot of responsibility and a lot of media, very, very welcome media that has resulted in actually hundreds of women, and I'm not exaggerating, hundreds of women contacting the charity wanting to become living donors. We have also got a benefactor or a number of benefactors that are supporting the program. And the most important thing, I think, is that we have given hope to thousands of women in the UK. But now we have to make this a reality. And from that hope, we are going to, I'm sure, we're going to make a great success of this program and make their dreams a reality. And finally, this has been a massive effort with not only the transplant and the gynecology team, but we have our anesthetists that have been instrumental in getting this going. And Reddy, our clinical pharmacist, has done all the protocols. She's been amazing. Our nurses, the radiology department and management. Without our direct managers, we would have never got this going. So and our immunology team, because they've been absolutely phenomenal, super supportive. So thank you very much. And we have no questions, but if you want to get in touch or if you have any questions, do contact us that way.
Well, thank you very much. Wonderful story, and the story actually belies an extraordinary degree of perseverance over many years. To get a program like this going in the NHS, even with charitable funding, is extraordinarily difficult. I cannot tell you how many hurdles Isabel has climbed over, and actually had to climb over the same hurdles several times in some cases. But many congratulations for doing that. It's very exciting. So our final part of today is to talk about the transplant research in Oxford. We heard lots of exciting things this morning about the way academic transplantation developed under Peter Morris's jurisdiction, and what we're going to hear now is a little bit about what's been happening more recently. I'm delighted to introduce two people. The first is Rutger Ploeg, who is my direct colleague, associate, and partner, who joined us, I guess, about a dozen years ago from the University of Groningen in the Netherlands, really with the objective of turbocharging our transplant research, our translational transplant research. And I have to say, he has been remarkably effective in doing that. So Rutger is going to tell us part of what we've been doing. The other speaker will be Fadi Issa, who is really the person who's taken over the mantle of cellular immunology from Catherine Wood, who was very much the leading light in the basic scientific side. Fadi is driving really exciting programs, which he'll tell us about in relation to cellular immunology and in particular cell therapy in transplantation. So Rutger and Fadi, I don't know if you are proposing to do this. I've lost Fadi actually. There you are. Thank you.
Thanks very much. Okay, Peter, thank you very much. I think Fadi and I are very happy to kind of dance this tango together, especially since Isabel, with her wonderful story, just announced that the relevant clinical programs are now finished. So I think it's time for us now to talk about our hobby in Oxford. And while, of course, I leave the last words to Fadi, who goes back to the prestigious work on immunology, which has been in Oxford for so long. I would like to add some of the work that we've been doing together with many very active and exciting clinical fellows, together with Peter and others over the past years. Of course, the issue at hand, we all know, is an increase in donation, but it's in high-risk donors. And of course, the challenge is that we have to kind of do this and use these organs, however, without kind of to the detrimental effect of outcomes after transplantation. And unfortunately, because there's so much uncertainty amongst those clinicians, and you all at the very night when you have to accept the offer, many of us decline because they think, let's wait for something better, and then finally the organs are discarded, which of course might be justified. Now, as you all know, there's a cascade of donor organ injury, which basically starts in this poor patient with, for example, a cerebral trauma or a subabdominal hemorrhage, becoming a donor. And then there's this period of donor management, retrieval, and then finally preservation, all kind of very much steps in the progress of injury. And then we accept the organ to work immediately, which we find kind of normal, although I must say often it's kind of a miracle. When we focus a bit on the management thing, we thought, well, we see the footprint, but we need the fingerprint, because assessment of donor quality is very difficult, and we haven't really advanced over the past 30, 40 years. So one of the reasons that we thought here in Oxford, why not set up a bioresource, which is now nationwide? And fortunately, NHSBT was ready to sponsor us. So we set basically hosted by our university, a national biobank, which collects all samples from donors, which is about 70% of all the UK donors in Oxford, sending with a very intriguing system back to Oxford, where we have samples from blood, urine, and tissues for national research and also for international research. And of course, these are the most important people who've been managed by Sarah Cross, and she has basically kind of helped to set up this biobank, which has a great impact on a lot of research in the UK. We have also added in the past years the Oxford Transplant Biobank, because we thought if we do something national, we should also have something local, and we have to kind of collect in the same way so that we have continuity between donor and recipient, which I think is quite important. Now, what can you do with this kind of things? Well, as we know, the donor management period could be a very harmful period for donors, because the organs all attached kind of might have a lot of cytokine upregulatory effects. There might be injury, and of course, when the injury is then cold stored, preserved, and reperfused, there might be a lot of non-function after transplantation. So a lot of our young researchers, like Kashabera, for example, have focused on what do we actually see during this period of donor management, and can we somehow detect certain profiles which are able to interrupt. Now, during my talk, of course, I can't go into the details too much because there's no time. So I'm taking you basic to Silverstone. I show you the cars. You see them racing by, but I can't go into the details. Another thing which is important, for example, is complement. We all know that complement activation is good. It's natural, but it can also be very harmful, and it happens in all donor organs already during organ donation. And this could contribute to a lot of ischemia reperfusion injury, also long-term evoking fibrosis. So would it be maybe possible to kind of downregulate this and prevent complement activation, which gives you better, lower immunogenicity and better donor organs? So we've done a lot of work on, do we actually see this complement activation? Because there are a number of inhibitors which you not only can use in your transplant model, but also in the donor. And there's precedent in the UK that we can give certain drugs which are reported to be safe to donors. So this is probably one of the next trials we're going to embark on. What about degradation? I mean, during stress and senescence of cells, there's a lot of degradation of proteins. And is that harmful or helpful? Normally, degradation is recycling the proteins, which is normal. However, if it goes over the top, it's not good for the quality of the donor organ. So can we somehow, using, for example, the quad samples, detect which parts of the kidney are degrading much more rapidly than you would expect? And if we know the patterns, are there strategies maybe to stop this, or maybe inhibit, or maybe reverse it? Because in the end of the day, regeneration is better than repair. Repair comes with scar tissue, regeneration doesn't. If you profile pre-transplant kidney tissue, are you able to predict the outcome of the donor organ? The donor kidney, the donor liver, the donor heart? Are there already markers present which tell you which so many months or maybe years after transplantation will predict whether your GFR at 1 year is high or low? Of course, in close collaboration with the integrated clinical data, but at the same time also some of the samples or the biopsies may tell you how to do this. And of course, the novel techniques of transcriptome, proteome, metabolome will tell you about the donor quality. You need, of course, experts in the Big Data Institute to help you to do modeling. And then, of course, you can relate it to, for example, the outcomes after transplantation, like the prediction of the GFR, but also to modern imaging techniques, which could help us to tell what is a good organ or what is a more risky organ. Mitochondrial biology is crucial during donation, preservation, and resuscitation of the donor organ. The mitos are our major energy sources and engines. If they do not work, it doesn't work to resuscitate the cell. We all know that organ donation and preservation stuns the mitos, and changes in the mitochondria will not be very helpful. Chris Watson always has this beautiful slide with the battery, you know, all your battery from your phone when it becomes kind of red. Same thing with the mitos. And the question is, of course, is can we keep it green or maybe uploaded so that it becomes greener after reperfusion? So, for example, Letitia Lofara, one of our senior scientists, very much focuses on this energy metabolism. And it doesn't only allow us to look at the donor, but also now, since we're doing perfusions, what happens actually during the perfusion strategy of either cold perfusion or a warm perfusion, and how do mitos respond to that? To have a very robust and sustainable transcriptome, proteome, and metabolome facility is very important. And Salah Shahid is one of our senior scientists who basically helps to do this. We do this also in close collaboration with Benedict Kessler's group from India. But in fact, he is very much helpful to kind of look at all sorts of samples we had come either from the recipient biobank or from the preservation trials we've done, or from Quad, to see what kind of effects certain stress factors will have on the proteome and the transcriptome. The other part, of course, is preservation. Well, Peter and I, over time, have become quite interested in organ preservation. And so it must have been kind of a coincidence that when I came to Oxford, we just had finished the first 10 years of developing novel machines, because the machines on the market for organ perfusion were quite rudimentary and quite simple and not very effective. So we thought in those days, in Groningen, with some NIH money from the Dutch NIH, why not start a new kind of prototype and develop something for kidney and liver, maybe for donor, which became a certain family, which then there was a spin-out company, Organ Assist, nowadays Ex Vivo, to look at oxygenation, which was new, but also hypothermic and normothermic use, and also the possibility to switch from hypo to normothermia. And at the same time, when we were doing this in Groningen, before I came to Oxford, and Peter had already started like 10, 15 years ago in Cambridge, together with a very young and promising engineer, Constantine Kusius, to work on the same concept for warm preservation of the liver. A lot of work followed, as you know, and the end product was beautiful, which was the Mitra by Organox spin-out company, and now there's also the kidney version. A lot of hard work, also convincing centers to do the first trials, which became very successful. So in a way, when we got together, we thought, well, we have to take this further. So we thought, why not make a European consortium and try these new strategies in real life. We went to the EU, we got 6 million, we had a lot of partners, and of course with those partners in those countries, there were about 50, 60 centers involved in whole countries participating in this endeavor, which was not only very exciting, but it was a lot of fun as well. And of course, as you know, one of the big outcomes was the beautiful paper by David and Peter in Nature about the NMP, which turned out to be safe and long for the liver transplants. So it is feasible. The question, however, is when do you use it and for how long, which is something he's working on now. The other two trials were kidney trials, either combined cold storage with oxygenated preservation at the end, or continuous oxygenated machine preservation in the cold with astounding and very positive results. Not only the trials were important, but also what we did with the biobank that was attached to the trials, because it allowed us now to look into the details of what was relevant and what actually was the strategy of either hypothermically or normothermically perfusing, doing to those organs. And Letitia worked very much on the liver, looking kind of at different phases of the biopsies, how these biopsies were affected by the time that they had been perfused, and were there certain kind of parts of metabolism more or less affected, and could that be steered or not? The same was done for the kidney, where we found that oxygenation was better for function, but also for graft survival and less rejection. And we looked in all sorts of details, which kind of proteins were upregulated or downregulated, and whether we could find a relationship with the immunogenicity. Now, when you do these trials and all these experiments, you also need a robust and sustainable facility. So when James Hunter joined us, having worked with Mike Nicholson in Leicester before he went to Cambridge, we set together with him a nice setup in the transplant biology research lab, where we're using slaughterhouse animals, animal house animals, and declined human organs, predominantly pigs. And I think very effective, because now in a very, let's say, robust way, we could do this work once a week, 1 or 2 kidneys, a liver, twice a month. And this gave also a lot of, let's say, food of thought for all those young individuals who came to us to do their research. This is, for example, something we did with Genentech, looking at one of the RIP kinase 1 proteins, which basically is something which produces necroptosis, which could be very detrimental after kidney ischemia and reperfusion, which is done by Isita Melati at a PhD project. We also had fungi who looked in the liver about the characterization of injury and inflammation of the liver, predominantly looking at cell-free DNA and nucleosomes, very interesting revealing kind of data coming out of that. There was also the model what Alexander Zeger did about acute liver failure and how you could actually try to see whether through cross circulation it would be possible to improve the biochemical and clinical hallmarks of acute liver failure, which was a wonderful model he has been using. And of course, there was also even attempts for the pancreas, which of course many of us surgeons never dared to touch because of the event of pancreatitis, which could be very detrimental. But Mo kind of took this on, and together with Julien Branchereau, who came to us for a period from France, set up a beautiful model for pancreas preservation, both cold and warm rewarming, which made a big difference and was very positive, which has led now to this trial, which is led by James and Mo on the donor pancreas that we are going to transplant. But first, we'll expose it to a few hours of oxygenated machine preservation to see whether the same positive effect is also possible in the pancreas as we've seen it in the liver and in the kidney. And of course, then there's the defatting, which is led by Hussein, together with Simon and Peter, where now they try to kind of to see how defatting of the liver in a trial fashion would be helpful to improve the quality of that liver during NMP prior to transplantation. Simon Knight set up this study together with Peter on the utilization of NMP, because the role of using more livers is probably more important than just kind of having better livers. NMP is quite good in kind of assessing the liver, and there is more trust and certainty with the professionals. So this trial will hopefully show that when you use NMP, there is better utilization. And not to forget that Simon, who's one of our specialists in the methodology and the statistics of clinical trials, can be also help decision-making in, for example, kidney transplantation by developing artificial intelligence, a beautiful project he set up, which is supported by the NIHR. And then finally, of course, a very big milestone was very recently when the new OrganOx kidney NMP machine was tested in a clinical study, phase 1, so it's about feasibility and safety, which was done by Richard Dumville, demonstrating basically that up to 23 hours NMP of the kidney is safe and feasible with good results. Obviously, this is a phase 1. So we have to see where it goes from here. But I think it is very promising that we have time to do something to those organs. And of course, then finally, what does it lead to? Well, I think that the future, at least that's what Peter and I think, is very much that we have to go to those so-called assessment and repair centers. There's a lot of ambiguous organs out there which are now declined. The straightforward organs can be transplanted right away, but I think the more difficult ones are the ones who should be tested and assessed, and maybe also repaired if possible. Ideally regeneration, but repair is already a good beginning. This is, for example, in some of our neighboring countries, people have advanced slightly more because maybe there's more money available than in the UK. This is, for example, the ARC in Groningen, which has been operational for 4 years now. But I think that the point is very much that we have to assess and resuscitate and decide, is it viable or not, which will increase utilization. We can also condition and repair. And of course, initiating regeneration is a big thing for the next 10 years. And it's very possible, I think, with the knowledge we have nowadays. Now, we have started slightly more modest in Oxford now in our fusion lab. As you can see here, the NHS gives us all the opportunities to do this. And these are the unpaid critical participants, which are Fungi and Richard, with pumping kidneys and livers to see whether these will be successful or not. It's working, it's getting there, and I think we'll get where we want. Of course, it's all about people who are behind the ideas, like we had in the COPE Consortium in 2013, and recently when we met again in Athens in 23. People make good ideas if there's trust and conviction, and it's all about collaboration. Thank you very much.
Well, thank you. Thanks very much for staying actually to the bitter end. And I'm actually going to bore you with some hardcore immunology. So I hope I can actually impart some of the wisdom that has been imparted to me over the years, coming up in actually one of the most significant cellular immunology labs in the world. So transplant immunology is a really delicate balance because you are trying to find a balance where the organ doesn't reject, but also the patient doesn't get infections and doesn't get cancer. So it's this balance between either too little and too much immunosuppression. And that is really the biggest question in transplant immunology, and the one that's been, since the origin of transplantation, trying to be answered. And our focus in the lab has been on trying to better control this balance, or finding a way of modulating the balance to find that happy medium in the middle. And there is evidence that you can actually do this. You can actually find balance. So this is a seminal paper from Rupert Billingham, Leslie Brent, and Peter Medower, where they showed that you can actually induce tolerance to an organ. So that means you can have a normal functioning immune system, but also be tolerant to a completely unrelated, mismatched tissue. And in this case, it was a piece of black skin on a white mouse. And they did that by injecting some cells from a donor mouse into the neonatal mouse and induced tolerance. So that was really seminal because it showed that you can do it, and we've been trying to do it ever since. So our aim really is to modify the immune balance between tolerance and rejection, and we want to tip it more towards tolerance. And the way to do this is to change the immune constitution, so the immune phenotype that patients have, to make them more regulatory. So Fiona spoke about this, about having regulatory cells, or previously T suppressor cells. But actually what we want to do is boost that regulatory cell population to try and move towards tolerance. So regulatory cells are really beautiful and complicated, but they're beautiful because they can act in so many different ways on so many different cells. Whereas when you give specific immunosuppression, you are focusing on a particular subpopulation of cells, but also it can be quite broad and toxic. Actually, Tregs can control all elements of the immune response, and that's why they are fantastic. So these regulatory T cells. So they can actually suppress T cell responses, B cell responses, antibody responses, and innate immune responses. So that is where our focus is. Fiona Parry spoke about her time in the NDS. And I wanted to highlight this paper from Fiona in 1994, so almost 30 years ago now. And this really was a landmark study which showed that you can control autoimmune responses in a mouse by giving Tregs. So she took these immunodeficient mice and gave them T cells to cause the mice to develop autoimmune disease. But then when she gave Tregs, at the time just defined by having CD25 expression, they had no disease. And that was really one of the first functional definitions of a Treg. Then this is Catherine Woods, who you've heard a lot about as well. But I also actually wanted to highlight Andrew Bushell, who's the effortlessly cool gentleman in the middle, who worked with Catherine for so many years, and his work really was integral to Catherine's success and the lab's success over many years, and sadly passed away far too early a few years ago. So they worked on the blood transfusion effect and on developing this Treg approach. And this really is, I think, one of the most important papers to come out at the time, where they actually did some transplants in mice and gave Tregs and showed that you can induce long-term survival of a skin transplant by just dosing mice with some Tregs. So I joined the lab trying to think about translating this to human. And actually, I was a recipient of one of those Royal College research fellowships that you heard about earlier, and interviewed by Peter Morris at the time, who was actually incredibly bemused that a plastic surgeon would want to be doing this.
and actually continued to be bemused whenever he'd see me in the lab actually doing work. And I joined to try and actually translate some of this work to the human and develop this model where you can actually look at human rejection within a mouse. So these are bits of human skin transplanted onto a mouse that gets a human immune system, and then you can look at the immune response in the skin and try and regulate it in the same way that was being done for in the mouse. And we showed that if you gave these animals a dose of human Tregs, so a single dose of human Tregs, you can extend the survival of that human skin transplant indefinitely in a dose-dependent manner. And similarly, if you transplanted these animals with a bit of human vessel, you could completely prevent the development of transplant arteriosclerosis. Again, in a piece of human vessel transplanted into the infrarenal aorta of these mice. So we then went to try and expand this to actually a clinical trial. And with our colleagues at King's, Giovanni Lombardi, and the GMP unit there, we developed this methodology for producing a clinical grade Treg therapy. And it's a very challenging process. It takes around 6 to 8 weeks in a single GMP clean room. And you can, at the end of it, produce a dose of human Tregs that can be frozen and used many months or even years later. So this methodology, I think, is really important, but it does need some work to try and shorten it to actually bring it into the NHS. So I've actually skipped about 20 years of work here, from when these cells were defined in the 1990s down to the identification of human Tregs and their expansion, and then into the first clinical trial of Treg therapy, which was the ONE study. And I have no idea what ONE stands for, actually. No one does. So the ONE study, which was a big European consortium, looked at whether you can give patients, renal transplant recipients, living donor renal transplant recipients, a dose of cellular therapy, eliminate their induction immunosuppression, and then see whether you can try to start to withdraw immunosuppression, particularly MMF, from month 9 onwards. So that trial was really successful in that the two groups of patients, so the cell therapy arm and the standard of care arm, had very similar rejection rates over the course of the trial. So it was found to be safe. And remember, this is a phase 1 trial. What was really surprising was that the patients who had the cell therapy had far fewer infection events, regardless of what cell therapy they got. And that was probably because they didn't have the induction immunosuppression, but also it just showed that the cell therapy was at least safe and didn't change the immune system the wrong way. And 4 of the patients who were treated in Oxford, so 4 of the 12 Treg recipients, are currently on tacrolimus monotherapy. No rejection events, fewer infection rates. So really very promising. So this is one of the celebration dinners where Catherine and Andrew looking at each other longingly. And I also just wanted to highlight Paul Harden there, the nephrologist who's been recruiting to the trial together with Matt Brooke here, because really without Paul, Peter and Matt, we wouldn't have been able to recruit to that trial. And to bring this full circle, this is the ONE study consortium. And you can see that there are a few familiar faces there. Peter Morris is there. But also Leslie Brent, who was on that first paper with Peter Medawar in the 1953 Nature paper. So he was able to see some of his approaches come into fruition. So what are we doing now? We've moved on to the next phase trial, which is the 2 study. We have no imagination. And it didn't stand for anything. And then we decided we had to make it stand for something. So transplantation without over-immunosuppression, which doesn't quite make sense, but that's what it is. The 2 study is a randomized trial. It's a phase 2 trial, and it's looking at trying to identify efficacy of the therapy. So patients either go into a Treg arm, and they have no induction immunosuppression, and then they have a dose of Tregs at day 5, after transplantation, and then their MMF is withdrawn at 6 months, or a control arm that have standard of care immunosuppression. And we've actually been recruiting to that for a number of years. We're actually over 40 patients at the moment. That may not seem like a lot. For a cell therapy trial, that is significant. We are the biggest Treg trial worldwide, recruited and treated more patients than anyone else in the world. And that really is a feat to the clinical teams and the lab teams. We're very interested in looking at these patients and seeing what happens in terms of the immune monitoring and the blood and the biopsy, etc. And I'm just going to give you a taste of some of the things we've looked at. The first thing to say is that the Tregs appear to survive in the peripheral blood. So if you give Tregs, depending on the dose, there's a spike soon after you give the Tregs, and then they sort of plateau, but slightly higher than the baseline. And the more cells you give, the more cells you can find in the peripheral blood, and that's that association on the right-hand side. But more importantly, if you look in these biopsies of patients who've had Treg therapy, you can see these very dense cellular infiltrates. And those, we wondered whether they were initially rejection at the time, but actually the patients were doing very well. They looked like potentially rejection infiltrates. And we wondered what was going on in them. So we did some spatial profiling. So this is looking at the transcriptome, so the RNA that's being produced by these cells in the biopsies, to see what they were expressing. And the patients who had cell therapy had this FOXP3 come up in terms of their RNA. And FOXP3 is the marker for Tregs, and probably some of those cells in those infiltrates are Tregs. And that's actually very interesting and reassuring. The other thing that came up is CD20, which is a B cell marker. And B cells have been quite closely associated with tolerance as well, patients. And then if you do some single cell sequencing, so you take all the cells from those biopsies and you look at each cell and what RNA it's producing from one of those tiny core biopsies, we found that the patients who are having cell therapy had an additional population of Tregs in that biopsy. So that looks like potentially the cell therapy. So cells going to the organs, important. I just want to touch on another trial that we were involved in. This was Alberto Sanchez-Fueyo's liver tolerance trial in London, where he's trying to give low-dose IL-2 to try and expand Tregs in the blood and withdraw immunosuppression. And he found that if you give low-dose IL-2, the number of Tregs in the blood go up, but actually the patients started to reject. So it was not very good outcome. And so we looked in those biopsies from the patients who had the low-dose IL-2 therapy in the liver. And what we found was that in the lobular areas of the liver, there was a loss of FOXP3 after you gave IL-2. So it looked like the Tregs were leaving the liver. You could see them in the peripheral blood, but they weren't in the liver where they needed to be. So we're now moving on to next generation Treg therapies. So we've been working on CAR Tregs. So these are Tregs that are specific for particular organs and producing ones that can actually make a regulatory suppressive cytokine, IL-10. And we're now also working on a universal Treg therapy. One of the big problems with Treg therapy is that you have to produce it from the recipient because it's an autologous cell therapy. And that doesn't necessarily work for lots of different types of transplants. So we're trying to develop universal Tregs where we genetically engineer the cells to not be recognized by the recipient's immune system, so that we can develop a sort of off-the-shelf therapy. And as transplant immunologists, actually, we are probably some of the best immunologists out there. I'm saying that with really we are, because we do understand both facets of immunology, both the rejection and tolerance sides of immunology. And we've been very fortunate in having lots of collaborations within Oxford, looking at other areas of immunology. And these are a few of the papers over the past few years, past couple of years that we've had the honor of working with. And so, for example, this one at the top, this was with Peter Ratcliffe and Chris Pugh. Peter Ratcliffe, actually, a few months after this paper was published, received the Nobel Prize. So I'm not sure if that's association or causation, but we're very proud to have contributed to that. I just want to show you some photos of the lab over the years. So you can see Peter Morris there. I'm not sure what he's holding. I think that's a knife. I think that's Chris Larson, I think. Oh yeah, it is. Yeah, Zoran Masson. Yeah. Oh there. And you can see Catherine Wood there, Catherine, Andrew, and Prof. Some of the many outings over the years. And this is actually the lab this week on Thursday. This is our standard Thursday evening do in the Trig lab. Just show you that the lab is still there, alive, and still producing some excellent work. And thank you very much.
Rutger, thank you very much indeed. Exciting whistle-stop tour through lots of wonderful science and some indicators as to what might be to come quite soon. Sanjay is going to say a few closing words.
Thanks, Peter. Well, Fadi was really impressive. I mean, I thought doing a difficult kidney transplant intraperitoneal at 3:30 in the morning is tough, but you know what? I would much rather do that than what you do. So we're sort of at that time of the day when we've got to say thank yous. Firstly, apologies that we've overrun. I'm not at fault there. So those of you who probably overran in your lectures, please. So a lot of people to thank. Firstly, all our guests, our patients who have made time to come here, all our guests who've taken time to come from all over the country and abroad. So thank you very much to all our speakers for a fantastic presentation. I only saw the last bit of it. I'm pretty chuffed that I actually sort of hid between you guys because mine was pretty rubbish. But also a few other people, the Oxford Transplant Foundation, Hansa Biopharma, Organox, Bridge of Life, the NDS, the organizing committee, which worked painstakingly, Peter Friend, Rutger Ploeg, David Cranston behind the scene, and David, without you, it wouldn't have been possible. But finally, and most importantly, Carol Bradford there. So it goes without saying that without Carol, this would not have been possible. And for all the truancy that all of us exhibit, she has been steadfast in her determination to get this day through.
So Carol, under normal circumstances, we will be presenting you with a large bouquet of flowers, but we are aware of the fact that you're setting off on holiday on Tuesday. So we thought that we would give you a placeholder, which will be replaced or rather supplemented by a bouquet of flowers on your return. So if you wouldn't mind stepping down, that would be an explanation.
Thank you, Peter. Thank you, Carol. So all that's left for me to say is thank you, and all of you have a safe journey back. Peter, any more housekeeping details? Please be safe. Do take the bus. We are slightly